Hello. 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 Mic check. Hello. Mic check. Hello. Mic check. Hello. Mic check. Hello.
Hello. Yeah.
Hello. Hello. Hello.
Hello.
Hello. सर वॉइस कैसे है? तो हेलो. 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 वॉइस ಬರ್ತಾ ಇದೆಯಾ? ಸ್ವಲ್ಪ ವಾಲ್ಯೂಮ್ ಸ್ವಲ್ಪ ಜಾಸ್ತಿ ಕೊಡ್ಬೇಕು. ಅವ್ರು ಮಾತಾಡೋದು ವಾಲ್ಯೂಮ್ ಸ್ವಲ್ಪ ಜಾಸ್ತಿ ಕೊಡ್ಬೇಕು. ಹಲೋ. ಹಲೋ. ಸರ್ ವಾಯ್ಸ್ ಬರ್ತಾ ಇದೆಯಾ? ಹಲೋ.
Hello.
ಹಲೋ.
Hello.
ಸರ್ ವಾಯ್ಸ್ ಬರ್ತಾ ಇದೆಯಾ?
Sir.
ಹಲೋ.
Hello.
ಹಲೋ.
Hello. 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 Hello.
ಹಲೋ ಸರ್. ಸರ್ ಇದು ಬಿಲ್ ಗೇಟ್ಸ್ ಅಂತ ಬರ್ತಾ ಇದೆ ನೋಡಿ, ಅದು ಪೇಪರ್ 1 ಅಂತ ಅದು ಬರ್ತಾ ಇದೆ ನೋಡಿ ಸರ್, ವಾಯ್ಸ್ ಬರ್ತಾ ಇದೆ ನಮ್ದು. ಬಿಲ್ ಗೇಟ್ಸ್ ಅಂತ ಬರ್ತಾ ಇದೆ. ಒಂದು ನಿಮಿಷ.
Hello. Check 1 2 check. Mic test check. 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 Hello check. Check. Check 1 2. Hello.
ಇಲ್ಲ ಸರ್, ಅವ್ರು ಮಾತಾಡ್ತಾರೆ.
Unmute ಮಾಡಿದೆ.
ಮಾತಾಡಕ್ಕೆ ಹೇಳಿ ಸರ್.
ಬಿಲ್ ಗೇಟ್ಸ್ ಅಂತ ಹಾಕಿದ್ದೀರಾ?
ಬಿಲ್ ಗೇಟ್ಸ್.
ಬೇರೆ ಹೆಸರು ಸಿಕ್ಕಿಲ್ಲ. ಪೇಪರ್ ಪ್ರೆಸೆಂಟೇಷನ್ 1 ಅಲ್ಲ ಅದು?
ಹೌದೌದು. ಇಲ್ಲಿ ಬರ್ತಾ ಲ್ಯಾಪ್ಟಾಪ್ ಸ್ಪೀಕರ್ ಅಲ್ಲಿ ಬರ್ತಾ ಇಲ್ಲ ನೋಡಿ.
ಒಂದು ನಿಮಿಷ ಇಲ್ಲ, ನಮ್ದು ಇಲ್ಲಿ ಕ್ಲಿಯರ್ ಆಗಿದೆಯಲ್ಲ. ನಿಮಿಷ ತಿಳಿಸಿದೆಯಲ್ಲ?
ಕೇಳಿಸ್ತಾ ಇದೆ ಲ್ಯಾಪ್ಟಾಪ್ ಅಲ್ಲಿ?
ಕೇಳಿಸ್ತಾ ಇದೆ.
ಲ್ಯಾಪ್ಟಾಪ್ ಅಲ್ಲಿ ಬರ್ತಾ ಇದೆ
ಅದಲ್ಲಿ ಇರಬೇಕು.
ಸ್ಪೀಕರ್ ಅಲ್ಲಿ. ಬೇರೆ ಪೋರ್ಟ್ ಗಿಟ್ ಬರ್ತದೆ, ಅದು ತಗೊಂಡು. ಹಲೋ ಸರ್, ವಾಯ್ಸ್ ಬರ್ತಾ ಇದೆಯಾ?
ಹಾಂ ಸರ್ ಬರ್ತೀನಿ.
ಹಲೋ
ಹಲೋ. ಹಲೋ. ಹಲೋ ಸರ್. ಸರ್ ವಾಯ್ಸ್ ಬರ್ತಾ ಇದೆಯಾ? ಹಾಂ ಸರ್ ಬರ್ತಿದೆ.
ಮಾತ್ರ ಬರ್ತದೆ, ಅಲ್ಲಿ ಬರ್ತಾನೆ ಸ್ಪೀಕರ್.
ವಿಡಿಯೋ ಕ್ಯಾಪ್ಚರ್
ಏನ್ ಬೇಕು? ಕ್ಯಾಪ್ಚರ್ ಕಾರ್ಡಾ? ಹಲೋ, ಇದು ಈ ಕಡೆ ಟೆಸ್ಟ್ ಪೇಪರ್ 1 ಅಂತ ನಡೀತಾ ಇದೆ. ಇದು ನಿಮ್ದು ಅದು USB ಕೊಟ್ಟಿದ್ರಲ್ಲ ಔಟ್ಪುಟ್, ಅದು ಇನ್ನೊಂದು ಏನಿದೆಯಾ? ರಿಜಿಸ್ಟ್ರೇಷನ್ ಆಫೀಸ್ ಬ್ಯಾಕ್ ಸೈಡ್ ಇದೆ. ಇದು ಕೆಫೆ ಇತ್ತಲ್ಲ, ಕೆಫೆ ಪಕ್ಕ ಮೇಲೆ ಕೆಳಗಡೆ ಇತ್ತು. ಮೇಲೆ ಕೆಳಗಡೆ ಹೇಳಿ. ಇದು ನಾವು ಮಾತಾಡೋದು ಕೇಳಿಸ್ತದೆ ಅವ್ರಿಗೆ, ಅವ್ರು ಮಾತಾಡೋದು ಕೇಳಿಸ್ತಲ್ಲ. ಲ್ಯಾಪ್ಟಾಪ್ ಅಲ್ಲಿ ಮಾತ್ರ ಬರ್ತದೆ.
ಅವ್ರು ಮಾತಾಡೋದು ಬರ್ಬೇಕಾ?
ಕೊಟ್ಟಿದ್ದೀರಿ?
ಕೊಟ್ಟಿದ್ದೀರಲ್ಲ.
ಪೇಪರ್ ಕೊಟ್ಟಿದ್ದೀನಿ.
ಇಲ್ಲ, ಹಾಕ್ಸಿ ಹಾಕೊಂಡಿರು.
ಗೊತ್ತಾಗಲ್ಲ.
ಹಾಕ್ ಸರಿ ಇದೆಯಾ?
ಕರೆಕ್ಟ್ ಆಗಿದೆ.
ನೋಡಿ ಇವಾಗ
Neocon.
ಸರ್
ಮಾತಾಡಕ್ಕೆ
ಹಲೋ.
ಕ್ಯಾಮ್ರಾ ಇಲ್ವಾ?
ಕ್ಯಾಮ್ರಾ
ಮತ್ತೆ ಹೆಂಗೆ ಬರೀ PPT ಮಾತ್ರನಾ? PPT ಇಲ್ಲಿ ಯಾವ್ದೇ PPT ಕೊಟ್ರು ನೀವು ಡೈರೆಕ್ಟ್ PPT ಪ್ರೆಸೆಂಟೇಷನ್ ಅಲ್ಲಿ ಪ್ಲೇ ಮಾಡಕ್ಕಾಗಲ್ಲ.
ಹೌದಾ ಸರ್?
ಇಲ್ಲಿ ನೋಡಿ, ಅಂದ್ರೆ ಪ್ರೆಸೆಂಟೇಷನ್ PPT ಅದಲ್ಲೇ ಹೋಗುತ್ತೆ. ಆದ್ರೆ ನೀವು ಇಲ್ಲಿ ಬಂದು ಇಲ್ಲಿ ನೋಡಿ, ಗ್ರೀನ್ ಕಲರ್ ಇದೆಯಲ್ಲ, ಇದ್ರಕ್ಕೆ ಹೋಗಿ ಹಿಂಗ್ ಹೋದ್ರೆ ನಿಮ್ಗೆ ಇಲ್ಲಿ ತೋರ್ಸುತ್ತೆ ನಿಮ್ಗೆ ಪಿಪಿಟಿ ನೋಡಿ ಇದು ಪಿಪಿಟಿ ಇದು ಮಾತಾಡಿ
ಹಲೋ ಹಲೋ
Hello.
can you hear me?
Yes, sir.
Is it clear?
Yeah.
Yeah, thank you.
ನಿರಂಜನ
ಅಷ್ಟೇ
ಇದೇನಿದು ಲಿಂಕ್ ಬೇಡ ಇದು ಇದೆ ನೀವು ಬೇರೆ ಎಕ್ಸ್ಟ್ರಾ ಎಲ್ಲ ಏನೇನೋ ಓಪನ್ ಮಾಡ್ಕೊಂಡ್ರೆ ಕನ್ಫ್ಯೂಷನ್ ಆಗುತ್ತೆ ಇದು
ಕ್ಲೋಸ್ ಮಾಡಿ
ಪಿಪಿಟಿ ಅಲ್ಲಿ ಪ್ರೆಸೆಂಟೇಷನ್
ಕೊಟ್ಟಿಲ್ಲ
ಅಲ್ಲ ನಿಮ್ದು ಪವರ್ ಪಾಯಿಂಟ್ ಎಲ್ಲಿದೆ ಇದೇ ಇದ್ರಲ್ಲಿ
ಮಾಡಿಲ್ಲ ಪ್ರೆಸೆಂಟೇಷನ್ 8 o'clock ಅಂತ ಸ್ಟಾರ್ಟ್ ಆಗಿಲ್ವಾ
ಬಿಲ್ ಕೊಟ್ಟಿದ್ದಾನೆ
ಇನ್ನೂ ಯಾರು ಕೊಟ್ಟಿಲ್ಲ ಸರ್
ಒಂದು ಯಾರು ಮಾಡ್ತೀರಾ
ನೋಡಿ ಈಗ
NNF ಅಂತ ಇರುತ್ತೆ ನೋಡಿ ಸರ್ಚ್ ಮಾಡಿ
ಸರ್ ಯಾವುದು
NNF ಅಂತ ಸರ್ಚ್ ಮಾಡಿ ಇಲ್ಲ ಸರ್ಚ್ ಮಾಡಿ
Neocon 220 only one right
ಹೌದು ಲಾಸ್ಟ್ ಬಿಟ್ ಒನ್ ಸೆಟ್ಟಿಂಗ್ ಇರಲ್ಲ ಸೆಷನ್ ಅಲ್ಲಿ
ಟ್ವೆಲ್ಲ ಸರ್ ನಿಮ್ದು
12
ಇಲ್ಲ ನೋಡಿ ನೀವೇ ಇರ್ತೀರಲ್ಲ ಪಿ ಪಿ ಟಿಯಲ್ಲಿ ನೀವೇ ನೋಡ್ಕೊಂಡಿರಲ್ಲ ನೋಡಿ 12 ನಂಬರ್ ಹಾಕಿದ್ದೀನಿ ನೆನ್ಪಿಟ್ಕೊಳ್ಳಿ ಯಾರೇ ಬಂದ್ರೆ ನಂಬರ್ ತೊಗೊಂಬಿಡಿ ನಂಬರ್ ಪಿ ಪಿ ಟಿ ನಂಬರ್ ರೀನೇಮ್ ಕೊಟ್ಟು ಎಲ್ಲ ಐತಿ ಈ ಫೋಲ್ಡರ್ ಹಾಕೊಳ್ಳಿ ಇಲ್ಲಿರುತ್ತೆ ಫೋಲ್ಡ್ರು ನೋಡಿ ಇಲ್ಲಿರುತ್ತೆ ನೀವು ಓಪನ್ ಮಾಡಿರ್ತೀರ ಅನ್ಕೊಳ್ತೀವಿ ಪ್ರೆಸೆಂಟೇಷನ್ ಈ ಪವರ್ ಪಾಯಿಂಟ್ ಮಾಮೂಲಿ ಇದೆಲ್ಲ ನಿಮ್ಗೆ ಗೊತ್ತು ಮಾಮೂಲಿ
ಇದ್ರಲ್ಲ
ಆವಾಗ ನೀವು ಇಲ್ಲಿ ಝೂಮಲ್ಲಿ ಏನು ಮಾಡಬೇಕು ಅಂದರೆ
ಈ ಕಡೆ ಬಂದಿದ್ದೀನಿ ಅವೆಲ್ಲ ಎಲ್ಲ ಇದು ಮಾಡ್ತಿದ್ರಲ್ಲ
ಲಾಗೌಟ್ ಆಯ್ತು ಮತ್ತೆ
ಇಲ್ಲ ಇದೆಲ್ಲ
ನೋಡಿ ಶೇರ್ ಸ್ಕ್ರೀನು ಕೊಟ್ಟ ತಕ್ಷಣ ನಿಮ್ಗೆ ಏನಾಗುತ್ತೆ ಆ ಪಿ ಪಿ ಟಿ ತೋರಿಸುತ್ತೆ ಇಲ್ಲಿ ಓಪನ್ ಆಗಿರೋದು
ಡ್ರೈವ್ ಓಪನ್ ಮಾಡಿ ಸೆಲೆಕ್ಟ್ ಆಗುತ್ತೆ ಸೈಡ್ ಶೋ ಫಿಲ್ ಕೊಟ್ರೆ ಆಯ್ತು
ಈಗ ಓಪನ್ ಆಗಿದೆಲ್ಲ ಇದು ಏನು ನಿಮ್ಮದು ಎಲ್ಲ ಅಕ್ಸೆಪ್ಟ್
ಅದೇ ಅಲ್ವಾ ತೋರಿಸ್ತಾ ಇದ್ದಿದ್ದು
ಇಲ್ಲಿ ನೋಡಿ ಇಲ್ಲಿ ಪವರ್ ಪಾಯಿಂಟ್ ತೋರಿಸ್ತಾ ಇದೆಯಾ ಇದು ಓಪನ್ ಮಾಡಿದ್ರೆ ನಿಮ್ಗೆ ಮಾಮೂಲಿ ನಿಮ್ಮದು ಹೆಂಗೆ ತೋರಿಸುತ್ತೆ ಹಂಗೆ ತೋರಿಸುತ್ತೆ ಪ್ರೆಸೆಂಟೇಷನ್ ಫುಲ್ ಹಿಂಗೆ ಕೊಡ್ತೀರಾ ನೋಡಿ ಶೇರಿಂಗ್ ಸ್ಕ್ರೀನ್ ಅಂತ ಇದ್ರೆ ಹೋಗ್ತಾ ಇದೆ ಅಂತ ಅರ್ಥ ನೋಡಿ ಯುವರ್ ಸ್ಕ್ರೀನ್ ಶೇರಿಂಗ್ ಅಂತ ಇದ್ರೆ ಹೋಗ್ತಾ ಇದೆ ಅಂತ ಅರ್ಥ ಕ್ಲೋಸ್ ಮಾಡಿ ಆಯ್ತಾ ಸ್ಟಾಪ್ ಮಾಡ್ತೀವಿ ಇವಾಗ ಅಷ್ಟೇ ಪವರ್ ಪಾಯಿಂಟ್ ಅಲ್ಲಿ ಓಪನ್ ಮಾಡೋದು ಇಲ್ಲಿ ಶೇರ್ ತಗೊಳ್ಳೋದು ಅಷ್ಟೇ ಗೊತ್ತಾಗುತ್ತಲ್ಲ
ನಾನು ಇರ್ತೀನಿ ಬಿಡಿ ನಾನು ಈ ಕಡೆ ಇಲ್ಲ ಆ ಕಡೆ ಬಂದ್ರ ತರ್ಸಿದ್ರೆ ಅಲ್ಲೂ ಚೆಕ್ ಮಾಡ್ಬೇಕು ನಿಂಗೆ ಇಂಟರ್ನೆಟ್ ಬರ್ತಾ ಇಲ್ಲ ಅನ್ನೋ ಹೇಳಿ. ನಂಬರ್ ತಗೊಳ್ಳಿ.
चलो कुछ करना, अब पहले तो शुरू तो हो जाए। ये इधर लगाया चेयर, चेयर कैसे लगाओगे, कहाँ बैठेंगे हम? चेयर वाले को कैसे अरेंज किया हुआ है?
नहीं आपको देना है।
मैं एक बार हॉल वाले को बोलता हूँ।
आ जाओ। इधर इस पे बैठना है क्या हमें? यार मतलब हॉरिबल बना है। haven't seen conference like this and all of them like
वहाँ पे चाहिए।
हाँ ये करते हैं, आ जाओ हेल्प करो यार।
मैं कर रहा हूँ।
ये चेयर को इधर करना पड़ेगा तभी तो थोड़ा
पीछे बैठने के लिए जजेस के बैठने के लिए वो चेयर नहीं है उधर, तो वो लगा हुआ है कुछ अपना टेबल लगा हुआ है, तो वो बैठेंगे कैसे? हाँ एक बार सर कर दीजिए, इसमें दोनों हॉल्स में एक बार प्लीज करवा दीजिए। आ रहे हैं सर, वो आ रहे हैं।
कोई बात, लेकिन शुरू कराना
हाँ,
पड़ेगा ना, टाइम लिमिट है ना, हमारा अपना लेक्चर है, बहुत सारा चीज है।
हाँ या आप स्टार्ट कर दीजिए, वो आ रहा है 2 मिनट में कर देगा सर, बोल दिया उधर वाले उस हॉल में क्या है?
So good morning. I think only participants are there. No?
Yes.
So I think good morning. I'm Dr. Lalan Bharti.
I'm Dr. Anupam
Manga. Right? So all the best to all of you. So,
Only two.
Only two. So I think first is Simi and Anuradha.
I think a few are there online, sir. I'm not sure. Yeah, sir. Because a few of our colleagues are also there and they're waiting online.
So you are?
I'm Dr. Vishwas, sir.
You start.
You can start now. Vishwas, you are Vishwas Rao.
Yes.
Right?
Yes.
Discharge in transport KMC quality improvement.
Yes.
Very good. So you can start now, Vishwas.
ऑनलाइन उसकी कैमरा नहीं
कुछ नहीं है सर, क्या कर रहा है?
हाउ कैन इट बी ऑनलाइन? वो आपको some of the people are in online. That's why.
So who will be coordinating for that?
No camera. How can I go through this online? No electronic. You have no arrangement for only online?
हाँ सर,
कहाँ है online में?
है ऑनलाइन।
चेक करना। इसका लॉगिन आईडी अलर्ट लॉगिन है।
There is no ID.
So better, it would be better, Dr. Vishwas, you
Yes.
start.
Yes, sir. I'm just loading it to the pen drive.
It was supposed to be held from 8 a.m.
8 to 10.
So then,
Now it is 9:20. Just
Canada keep going like this.
can shoot right. Even if it's staying, it is shoot.
Hello. Hello. यहाँ की कुछ यहाँ पता है कोई अरेंजमेंट नहीं है, चेयर है बैठने के लिए। किसको? हेलो हेलो
Online arrangement नहीं है.
हेलो, हाँ दिनेश, हेलो,
ಇದು pen drive ಕೊಡ್ಲಾ ನಿಮಗೆ?
so you have to be very brief now. You have to cut short the presentation.
pen drive
हाँ सर, pen drive.
ಇದಕ್ಕೆ ಹಾಕೋದಾ?
हाँ ಅದಕ್ಕೆ ಹಾಕಿ.
ಲೈವ್ ಇದೆ ಇದರಿಂದ
ಲೈವ್ ಅಂದ್ರೆ ಇದು
आवाज नहीं आ रही है.
ಹಾಕ್ಬೇಕಷ್ಟೇ.
हेलो,
ನಮ್ಮ ಪ್ರೆಸೆಂಟೇಷನ್ ತಾನೆ
ಹೌದು.
ಇದು ಲೈವ್ ಇದೆ ಎಫ್ಎಸ್ ಇದೆ ಇದರಲ್ಲಿ.
वो भी कह रहे हैं कहीं जाना है उनको, वो तो मेरे को कह रहे हैं कि आप कर दो, मैं नहीं दूंगा. He is saying like that. तो नहीं नहीं, वो मेरे साथ है ना. नहीं, अच्छा आपके दूसरे हॉल में थे पहले.
हम उधर में गए थे.
अच्छा,
तो हम
ಜಾಯಿನ್ ಆಗಿ
तो बड़ा है इबोला हॉल. किसी की इबोला हॉल.
ये तो कह रहे हैं इबोला हॉल में भेजे, ये आप खुद आए हैं. ठीक है.
हाँ. इधर में हम घूम के चल जाएंगे.
अरे मैं ममता को भी बोला हूँ,
हाँ।
ममता जाजू को। अच्छा भेज दो, अरुण करेंगे, ठीक है भेज। यहाँ कुछ है, यहाँ ऑनलाइन का नहीं है बट ये चेयर लगवाया क्या इधर? कहाँ गया उनके?
3 hours to just inaugural, it will take 3 hours to just inaugural.
ये चेयर तो लगवा दो।
मैंने बोला है सर, वो आप उस हॉल में आ जाइए सर, वो डॉक्टर तोमर से बात हुई हुई है।
हम इधर के नहीं,
नहीं आप इधर डॉक्टर अरूप का है, आप उस वाले में आ जाइए सर, उधर आ जाइए। डॉक्टर अरूप
थैंक यू।
ಯಾರು ಮಾಡಿದ್ದು? ನೀನ್ ಮಾಡ್ದ?
ಎಲ್ಲ ಕಡೆ ಲೈವ್ ಬೇಕು.
ಯಾರು ಹೇಳಿದ್ರು? ಯಾರು ಹೇಳಿದ್ರು?
ಅವರು IT ಮ್ಯಾನೇಜರ್ ದರ್ಶನ್ ಬಂದಿದ್ದ.
ಇಲ್ಲಿಗೆ ಆನ್ ಮಾಡಿದ್ನಾ? ಇಲ್ಲಿ ಲಾಗಿನ್ ಮಾಡ್ಕೋದ್ನಾ?
You are doctor?
Anshul Deva.
From where? Achal from Chandigarh.
No, from MP sir.
Achal sir. What is duration of your presentation? 8 minutes. Yes. And you have to cut short.
MP presentation here. This one is. No.
ಮೇಲೆ ಐತಿಲ್ಲ, ಅದ್ರ ಮೇಲೆ ಐತಿಲ್ಲ. ಇದಣ್ಣ?
Third last.
ಕಾಪಿ ಮಾಡಿ. ಮಾಡೋಣ ಬದನೆ.
ಜೂಮ್ ಇಲ್ಲ ಅನ್ಸುತ್ತೆ.
ಐತಣ್ಣ?
ಕನೆಕ್ಟ್ ಮಾಡಿಬಿಟ್ಟು ಅಷ್ಟೇ, ಯಾರು ಮಾಡಲ್ಲ. ಮತ್ತೆ ಇಪ್ಲೇ ಮಾಡ್ತಾರೆ.
ಇಲ್ಲಲ್ಲ
ಬಿಡು ಆಯ್ತು.
ಇದು ಪೇಸ್ಟ್ ಮಾಡೋದು
तो ऐसे होगा.
You were sitting there also, no?
Yes.
People are waiting for you. Even there.
नहीं I'll do it. But प्रॉब्लम है कि ये ऑनलाइन भी होगा बच्चे.
हाँ,
ये तो ये कहाँ से
वर्चुअल भी है और इसमें तो सारे वैसे हैं आपके तो। यहाँ पे ये सामने वाले नहीं वर्चुअल, यहाँ नहीं है।
यहाँ कोई वर्चुअल नहीं.
यहाँ नहीं है, देखिए सर, यहाँ पे सामने वाले नहीं है।
ಒಂದೇ
वाले पे virtual नहीं है।
ಇದು ಒಂದೇ
इसका हो गया. आपका आंचल हो गया आपका.
हाँ जी।
So you please start.
Okay sir.
Okay, start. आपने चेयर नहीं लगाया इधर. सॉरी सॉरी वो चेयर नहीं लगाया इधर, कैसे बैठेंगे उसमें?
किधर से उधर?
कहाँ बैठना होगा?
Just stand here and put them.
You start.
Okay. Good morning, everyone. I'm Dr. Anshul Sachdeva. Presenting paper under free paper category in Neocon 2021. The topic of my work is evaluation of extended sick neonate score to predict immediate outcome of the sick neonates, the neonates who are admitted in an ICU. The neonatal period is the most vulnerable time for a child's survival. Currently, The neonatal mortality rate of India is 23 per 1,000 live births. India aims to reduce it to 16 by 2025. The highest risk of death is in first month of life. What are the causes? Prematurity, sepsis, and asphyxial deaths. These are the majority contributors of the mortality in first month of life. Yeah, there are many other causes which are shown in this pie chart which are causing the mortality. This extended sick neonate score, which is we are using here to predict the mortality in an ICU, is consisting of the clinical parameters only. This can be used in any resource limited settings. Now, can this mortality score be used to predict the course during hospitalization and outcome of those neonates who are admitted in an ICU? Keeping this question in mind and to predicting the course, we are moving up with the study. The study aims to determine the outcome of sick newborn using this extended sick neonate score. Outcome in terms of what? In terms of death, in terms of discharges, in terms of duration of stay, in terms of need of ventilator support, in terms of need of oxygen therapy, right? Now, this was a prospective observational study done during March 2020 to August 2020 in Department of Pediatrics, Gandhi Medical College, Bhopal, that's an MP, taking 220 neonates. All the term neonates admitted during this period were enrolled. Those with a congenital anomalies and requiring the surgical intervention immediately were excluded from the study. There was a pre-tested pro forma used, there was new Ballard scoring sheet used, and there was this scoring system, extended sick neonate scoring system. This score is consisting of 9 parameters. These are more or less the vitals at admission, the respiratory effort, the heart rate, mean blood pressure, axillary temperature, capillary filling time, random blood sugar, saturation, Morrow's reflex, and modified Downey score. These are the 9 parameters used. The minimum score is 0 and the maximum score is 18. 9 into 2 is 18, right? So we have total term neonates during the study period 272, of which 52 were excluded from the study by exclusion criteria. So 220 neonates were enrolled in the study who were fulfilling the inclusion criteria. Of these 220 neonates, 178 got survived and discharged and 42 participants died. Coming to the statistical analysis in our study, the quantitative data was expressed in mean or median. For the normally distributed variable, student t-test was applied, and for not normally distributed variable, Mann-Whitney u-test was used. The qualitative data was expressed in percentage, and to compare these percentage, the chi-square test was used. To predict the immediate outcome using the extended sick neonate score, we have used this receiver operating characteristic curve. This was used to predict the cutoff value. The p-value of less than 0.05 was considered significant in this study. Now coming to the result part, using this receiver operating characteristic curve, the ESNS, the extended sick neonate score cutoff value came out to be 13 score. Hence, these 220 neonates were divided in 2 groups and compared. Actually, there was a gross difference. There was marked difference in the immediate outcome of the neonates who scored 13 or more than 13 or less than 13. So total 220 neonates were divided and compared. 37% scored less than 13 and 62% scored more than 13 or 13. The mean score came out to be 13.16. This is the ROC curve showing the ESNS score of 13, which came out to be significant statistically. Now, association of extended sick neonate score with the immediate outcome in terms of discharges and death. As we can see here, 98.5% of the participants who scored more than 13 got discharged and only 1.5% had mortality. But what for those who scored less than 13? 51% got discharged and this 48.1% died. So there is a p-value which is significant for each observation. This graph is showing the same. High number of percentage patients got discharged in more than 13 group and more number of mortality was there in less than 13 group. Coming to the immediate outcome in terms of duration of stay, what has happened to them? In duration of stay, there was longer stay with those who scored less than 13 and a shorter stay to those who scored more than 13. This is a graph showing the same with significant p-value. Now, for oxygen therapy, the p-value didn't come out to be significant. For the ventilator support, we can see the more need in number of days of duration of ventilator support was needed for those who scored less than 13 to who scored more than 13. This was the previous study. There is just one study, IAP article. ESN is predicting the mortality. This was done by Ray et al. And a prospective observational study, which had this 11 as a cutoff value for predicting just the mortality and not the course during hospitalization. This was having the sensitivity of 85.9% and the specificity of 89.8%. In the current study, this is a prospective observational study. Our score is a 13 cutoff value with a sensitivity of 75.8 and 95.2 for predicting the mortality. There was another study using this modified sick neonate score predicting the mortality done by KP Mansoor et al. This was a cross-sectional analytical study. This had also predicted the same, that is just the mortality. There are many other scoring systems which are used as mortality scoring systems, Crib, SNAP, SNAPE, SNAPE2, many other mortality scoring system. But this study is the first study which has predicted the mortality as well as the course during hospitalization. The strength of this study, this ESNS can be used to predict the immediate outcome with a sensitivity of 75% and specificity of 95%. Being just a clinical score, it can be used in any resource limited settings and countries like ours. Now, what is the limitation? This was a single center study done in just our department. So the findings cannot be generalized. To conclude the work, the significant association was found between the extended sick neonate score and outcome in NICU. Along with that, there was significant association of ventilatory need and the duration of NICU stay. These are the references I have put in my study. Thank you so much.
Thank you, Achal. It was a good study. So what was the shortcoming in your study while using this score? What was the bottleneck?
Sir, actually, the first practical thing I have actually faced in my study, practical problem which was there, the patient coming at day 10 to our center and the patient coming at first hour of life.
Okay.
I was like, patient has received something already. Patient has improved in those 10 days. Patient has received treatment from somewhere. Patient has not received treatment. Patient has just went home and patient was ill there at home only. And the patient who is coming to us at first hour of life. I felt like I lagged that thing. I have missed that part. I couldn't enroll.
So you have mentioned 9 parameters.
9 parameters, yes.
9 parameters. You also mentioned the blood pressure in that parameter.
Yes, sir.
How did you manage to get the blood pressure in all these babies?
Sir, non-invasive blood pressure monitoring.
That was there in your
settings, sir.
In casualty.
In an ICU, sir. Thank you so much.
Because of want of time, I'm cutting short.
Okay.
Next is
Dr. Vishwas.
Dr.
Vishwas. Good morning, everyone. Shall I start, sir?
Yeah, please go ahead.
Good morning, everyone. I'm Dr. Vishwas. I'm the DM resident at St. John's Hospital, Bangalore. So today I'll be presenting my QI study on transport KMC. So coming to transport during low birth weight is obviously a stressful situation where from a controlled NICU setting, we are shifting the baby to outside environment. So KMC, as we all know, is a standard of care. It's been validated by the WHO, and it's a time-tested intervention to improve the low birth weight survival. Skin-to-skin contact as well is a proven method of transport, but although it's not very well established, and we wanted to combine the goodness and the advantages of KMC while doing discharge and discharge in KMC. So what is the routine? So routine is a parent and attender taking a baby in a contraction like this. So the problem with this contraction is the fact that there is separation. Usually it's not the mother who's carrying, it's the attender, the grandmother, the father. There is, we felt that there is reduced bonding because of all this. The safety is questionable in a contraction like this. And the temperature control is obviously questionable as well. The obvious the disadvantage being the size. The size of the contraction is too big and the baby is too small. So we felt that this was where we had to get our focus. So our smart aim was to improve transport KMC at discharge for all low birth weight babies from less than 1% at presently in our hospital to greater than 50% in 6 weeks. So this was our team, which included doctors, postgraduates, nurses, as well as security staff. It was a team effort. And so what are the outcomes we studied? The first outcome, primary outcome, was to see the number of babies less than 2.5 kgs who were discharged home in transport KMC. The secondary outcomes were to see the number of babies who actually reached home in transport KMC, to see the number of interruptions during this discharge in transport KMC. And the last one was to see how many of these babies actually reached euthermic when they reached in discharge at transport KMC. So inclusion criteria include all the inborns and outborns who are low birth weight, that's less than 2.5 kgs, discharged from all the wards in the hospital. This included an ICU, postnatal ward, and other wards as well. And the exclusion criteria were obviously all the DAMAs or the referral of the sick neonates, which we didn't include. So the first thing we did was analyze and measure the quality of care through this fishbone analysis, and we found that these were the lacunae. First, in terms of person, we had lack of awareness, we were understaffed, parents were untrained. Policy, there was no real written policy on how to transport in KMC. Preparedness, the safety of the said procedure was still in discussion. Training was a problem. The adaptation of this whole policy by all the members was a big problem. And of course, KMC bags was the integral part of this whole process. In terms of procedure, there was no routine KMC ambulation, and this was something we had to really try. So these were the problems we felt. So to understand and improve on this, we tested with multiple PDSA cycles. The first PDSA cycle, we did a policy decision making to send all the babies less than 2.5 kgs in transport KMC. We did a standard operating procedure. The SOPs were formed. Project and policy briefing was done to the department, as well as the video of how to transport KMC was done. So what is the SOP? SOP was very simple. During the hospital stay, identify the low birth weight babies soon, train all the mothers with the use of KMC binder. Prolonged KMC is something we wanted to achieve in this whole process. At the time of discharge, make sure the mother knows how to put the baby in KMC. Temperature of the baby, the KMC baby was to be monitored, and ambulation was something we wanted to supervise. After discharge, we called up the parents to find out what the temperature the baby reached the home at, and also the photographs of the babies with the mobile phones, as well as parents were, we filled a Google form with this. So this was the Google form which we used to send the baby in discharge at transport KMC. So learning after the first PDSA cycle was 90% of babies were discharged in KMC, and parents and staff were very compliant. They had no issues, and only 83% actually were euthermic. So this was the problem which we recognized very early. So in the second PDSA cycle, we wanted better compliance. We wanted euthermia for the babies as well. So we wanted to ensure early KMC, train the mothers in KMC ambulation, procure more bags, which was an issue. And for euthermia, we wanted babies to be discharged only during daytime. The windows being open was something we realized was a problem, and the right method of temperature measurement was something we realized was a problem. So we wanted to address all of this. So we made a video to show the parents how to actually measure the temperature, and this is the screenshot of that. So the learning after second PDSA was parents were becoming more compliant, but babies were getting missed, especially in the COVID side. So that is something we wanted to address during the third PDSA cycle, where we actually did the root cause analysis of all the missed babies, trained the sisters in various wards. So this was an ongoing process during these PDSA cycles. So at the end of the third PDSA cycle, we were achieving about 90% of low birth weight babies in transport KMC. Babies were reaching euthermic more often, and long distance travel up to 120 kilometers was actually done without interruption with this transport KMC. So what is the results of my study? First of all, during my 6 weeks period, total number of low birth weight babies delivered were 85, out of which 59 were eligible for discharge at transport KMC. The good thing was NICU, we achieved 100% of transport KMC. So all all the babies in NICU actually went in transport KMC. Postnatal ward achieved 82% and COVID ward achieved 60%. So as you can see, we had a wavering. Initially started off with 90, we achieved 100% of babies in discharge who were in transport KMC as well. So as a whole, it was 89% of low birth weight babies who were discharged in transport KMC during this entire period, which was a big success for our study. Coming to the babies who, the temperature of these babies when they reached, what we found out was among the 53 babies whose temperatures were measured, 86% of them were euthermic. And out of the other 13%, they were all cold stress. So there was no moderate or severe hypothermia. So this again was a validation of our study as well. So this is the percentage of babies in euthermic. As you see, as the PDSA cycles went on, the temperature at which the babies reached on got better. So that again emphasized the results of our PDSA cycle. And as a whole, 86% of all low birth weight babies actually were discharged in transport KMC. Other outcomes were 98% were discharged in KMC without any interruption, which was again a big success. And what we also achieved while doing this PDSA cycle and this QI project is the mean hours of KMC at our ward also improved. It was very low at around 5.5, 6, although our strive for KMC hours is quite high. So it went up to 8.5 hours as we went along. So among in the sustenance phase, though, we had issues. As you see, till 6 weeks, that was our PDSA cycle. Our percentage of babies discharged in KMC was very high. But during the sustenance phase, you can see it slowly going down to 75, 83, 71, and at last 66. So what is the result of my sustenance phases? Although 66% of babies were discharged in transport KMC, and NICU had actually achieved 100% of transport KMC, healthcare workers in postnatal ward everywhere required continuous motivation to actually enforce this policy. So road forward is we need constant motivation for discharge at transport KMC. Parents need to be called and enforce this whole process of KMC. And on follow-up, we asked babies whether they were actually transported in KMC or not. So to conclude this study, the QI project, transport in KMC is feasible and an acceptable norm in low birth weight infant transport. Sustenance requires continuous reinforcement both for healthcare workers as well as parents. And transport KMC provides a good opportunity to improve the KMC hours in both hospital and at home. Thank you, everyone.
Thank you. Thank you. Well, and a very good presentation. And did you measure the quality of KMC given, for the example, in terms of duration?
Yes, sir. So we initially did a baseline study of how much was the hours of KMC that was given, and we found it was at around 4.5 hours. So as we went on to the QI project, although our main primary outcome was to see the discharge and transport KMC, we also found that the number of hours of KMC had also increased to 8.5 hours. So it had almost doubled during the process of our QI studies.
So who was giving the KMC during transportation in the study?
In
Majority?
Mothers. Majority of them was given. So we had trained the mother, we had shown her the videos, we had shown her how to put the KMC harness, and we had actually seen her ambulate with the KMC bag as well. So all these were training that were given in the 3 days of the stay in the postnatal ward before we send them in discharge.
Was there any other person besides mother?
Yes.
The attenders, usually the mothers, the grandmother used to usually be there.
That
Yes, sir. We used to, foster KMC is something we continuously promote in our postnatal wards, but the primary caregiver is whom we used to actually ask them to, actually go in transport KMC, but foster KMC is something we promoted as well.
Thank you. Next, please.
सिमी अनुराधा आप फर्स्ट से बुलाइए, फिर अभी तो बीच में हमने शुरू कर दिया था. सिमी अनुराधा
नहीं है.
Yes.
You are
Second. Alarm safety in tertiary care.
Helam. Hector. Okay.
I have 3 papers.
You have 3 papers.
Yes.
Acha.
2, 3, and 4.
Yes.
2, 3, and 4. So you will be doing continuously. Huh?
We can have someone in between for one.
No.
How many minutes?
6 minutes. Sorry.
6 minutes.
And you have to cut short. Can you do it?
I'll try.
We are running late.
We are
Yes,
running late, so you need to cut short.
Yes, sir.
Huh?
You are responsible for it.
No.
So you're punishing her.
She came late, no?
No, she was here.
अरे मेरा तो दूसरा हॉल में था ना.
अरे मेरा भी दूसरे हॉल में था. ये तो चक्कर है यहाँ पे. ये कुर्सी साफ किया है हमने बैठ करके यहाँ.
Only the presenters and the nobody else.
कलकत्ता में हम लोग पहले से आके सब कुछ ठीक से कर देंगे.
कलकत्ता तो ऐसा बेंचमार्क हो गया ना कि कलकत्ता कुछ भी एयरपोर्ट पर भी करेगा तो हो जाएगा.
But you will do the first one. Alarm safety.
Alarm. First you do the alarm safety.
Okay, sir. One second, sir.
कौन सा? दूसरा वाला कौन सा? आपको जो दिया वो इसमें आप निकाल दो.
Sir, I'll try to cut short. Actually, we're told about 8 minutes.
You start.
Yeah.
Then the you will be called as a judge.
यही तो अभी पता
We
नहीं
will call you a judge.
इनका स्टूडेंट है यहाँ पे
We will call this some other hall. You should be ready for that.
अच्छा ये दिनेश मेरा तो दूसरा हॉल में था वो
अरे आप अभी आ जाना तो देखते हैं.
नहीं
we have to settle in Calcutta in a nice way.
Okay, so start. You
Your
start.
time.
Your time start now.
Good morning, everyone. I'm Dr. Hetal Budd from Gujarat. The title of the paper that I'm presenting today is Alarm Safety in a Tertiary Care Neonatal Unit of a Medical College, and this was a quality improvement study. As we can see, we all know that pulse oximeter plays a vital role in monitoring the sick neonates. But also false alarm rates are very high for these pulse oximeters, and they often cause desensitization of the staff, leading to inattention to clinically important alarms. Also, because of these false alarms, there is transient loud noise and repeated disruption of the sleep in the neonate, which can cause short-term negative impact on the cardiorespiratory system as well as poor neurodevelopmental outcome. Hence, the entire NICU team felt the need to do a quality improvement study regarding this. The objectives of this study were to reduce the burden of false alarms and alarm fatigue, and also to improve the response time to the alarms. The study was divided into 3 phases. That was the baseline phase, the implementation phase, and the sustenance phase, which was conducted over a duration of 6 months, that is from the November 2019 to May 2020. The main stages of this study were divided into 4 parts. The first was identification of the problem, team building and construction of SMART aim, analyzing the problem and measuring the project indicators, developing and testing changes in the implementation phase, and sustaining improvement. The baseline phase was conducted over a duration of 90 hours spread over 30 days, that is 3 hours each day. And during this time, alarms for the heart rate and saturation, oxygen saturation were evaluated along with response to them within 30 seconds. We found out that the major causes of the false alarms were movement of the newborns in 48%, inappropriate alarm limits in around 23%, and loose probes in around 27% of the neonates. We did a fishbone chart and plan do study act model using the point of care quality improvement principles, which were developed by the AIMS Delhi and WHO. Here we have the fishbone analysis, in which we concluded that for policy, people, procedure, and place, we were lacking at certain points, like there was no written policy in our unit for the probe, and there was no supervision for checking the response to the alarms. Also, no SOP was there for attachment of the probes, and for every shift of the nursing staff, they were not checking the probe site, and there was no appropriate probe changing with every shift. The staff was not trained to adjust the alarm limits, and they were not aware about the hazards of alarm fatigue. Also, we were using different brands of pulse oximeters, which were one of the causes. During the PDSA cycle in the implementation phase, the duration was 93 minutes over 31 days, and here the staff was trained to adjust the 93 hours over 31 days, so 3 hours for each day. The staff was trained to adjust the alarm limits using the reference chart, and a lecture was also taken on the hazards of noise pollution. Here are some of the pictures that we have taken during the staff training during the study. During the sustenance phase, the duration was around 66 hours, and here the components of the first PDSA cycle was strengthened by supportive supervision and guidance to the new staff. The statistics that we used were descriptive statistics like frequency, test of proportions, chi-square test, run charts, and a p-value of less than 0.05 were considered significant. Here is the first PDSS cycle that was done during the implementation phase, where we decided the alarm limits and trained the staff. Then we used the reference chart to set the alarm limits. Hands-on training were given along with lecture on hazards of noise, emphasis on muting the alarm immediately and changing the probe sites regularly. We studied that during the implementation phase, the appropriate alarm limits improved from 14.2% that was seen in the baseline to 73% in the implementation phase. Also, the false alarm rates decreased from 0.39 to 0.22. That is false alarms per patient per hour. And the response to true alarms was improved from 77% to 90%. After this, we adopted the policy. Training of the new staff was done who joined NICU, and we helped the staff in real life situations. Now, this is the second PDSA cycle during the sustenance phase. Here, if we look at the study part, we observed that the alarm limit further improved to 85%, and the false alarm rates reduced to 0.16. Also, we are able to reach 100% response to the true alarms. This is a concise results in the table where we can see that the hours of observation for baseline, implementation, and sustenance phase, as we saw in the previous slides. Here we can see that the total alarms which were observed in the baseline phase was 494, which reduced to 162 at the sustenance phase, which was statistically significant. Also, the total alarms rate per patient per hour has reduced to around 50% in the sustenance phase. The false alarm numbers has also decreased. The false alarm numbers has also decreased to 61% from 73%. We used indicators like the process and outcome indicators. The process indicator was appropriate alarm limit, which has increased from 14.2% to 85%, which was statistically significant. And outcome indicators like false alarm rate per patient per hour has decreased to 59% as compared to the baseline. And the total alarms responded has increased to 73.5%. That was 2.2 times more than that of the baseline. And the percentage of true alarms responded was 100%. All this data was statistically significant. These are the run charts that we used, and which shows the daily false alarm rates, which show that in the baseline there was a median of 74.34, which has reduced to 55.56 during the sustenance phase, that is post second PDSA cycle. Here we have total alarms and response to them during the baseline, post PDSA cycle 1 and post PDSA cycle 2. Here we saw that the baseline median was 35.5, which increased to 77.8%. We concluded that the major causes for false alarm were the excessive movements, inappropriate alarm limits, and the probe-related problems. And after the QI study, we observed that the false alarm rates were reduced, response to the total alarms improved, and the response to the true alarms was achieved to 100%. Thank you.
Okay, thank you. Very good study. So this is the known fact, right?
Yes.
And what were the this thing, pulse oximeter you were using? Masimo's or?
Sir, we have Massimo, we have Philips. Those are the two main that we use.
Okay. So how did you train your nurses or staff in recognizing the false and true this thing?
First of all, we had to define what was false and what was true. True alarm was defined as any of the alarm which was caused either due to desaturation or bradycardia or tachycardia, which needed medical intervention. That was considered as a true alarm, and false alarm was that it was maybe because of those reasons. Once they were defined, we advised the staff about how to identify. For that, the residents and fellows were always there. After that, as we went on, changing of the probe site, making the probe tighter to not make it loose, and setting proper alarm limits, that was done.
Have you intensified the decibel or anything else in the false alarm or the true alarm? What is the collective decibel if the false alarm and the alarm is there? Anything measured decibel?
Yes, yes. Okay, noise in decibels we have not.
Huh?
Noise in the decibels we have not.
How will you ascertain which one is the effective, which is not effective? What is how much the decibel?
Sir, the alarms decibel for true as well as false was the same. We just attempted to reduce the number of false alarms because during the baseline we saw that around 70% of the total alarms were false alarms. So we wanted to reduce that proportion.
That the false alarm of the 70% has been a harmful effect on your neonates and any others.
Yes, as we say, there is transient loud noise can cause results like sleep disruption, and also cardiovascular parameters can get altered for a short duration.
Okay, thank you. Next.
Next, you are going to present next also.
Yes.
You will see pretty very much.
Can start.
Shall I start, sir?
Yeah, start.
My second topic is effect of kangaroo mother care on cerebral hemodynamics in preterm neonates assessed by transcranial Doppler sonography in the middle cerebral artery, and this was a prospective interventional study. We all know that the neonatal period is a critical period for the development of brain and maturation. Also, the preterm neonates have immature cerebral vasculature and vasoactive signaling. And because of the ineffective cerebral autoregulation in the preterm neonates, this can cause marked fluctuation in the cerebral blood flow. Early KMC positively influences the preterm brain networks and also facilitates the formation of neural connections, which leads to better long-term neurodevelopmental outcomes. However, the effect of KMC on cerebral blood flow and its dynamics have not been studied well. That was the reason that we conducted this study. The objectives were to study the cerebral hemodynamic changes in the middle cerebral artery using transcranial Doppler before and after KMC, and also to determine the correlation of cerebral blood flow parameters with the gestational age and birth weight. Since this was a prospective interventional study, the study place was level 3 NICU of a university affiliated teaching institute over a duration of September 2020 to May 2021, and the institutional ethics committee approved for the study. We included all clinically and hemodynamically stable preterm neonates from 28 weeks of gestation to less than 37 weeks of gestation who were admitted either in the NICU or the KMC ward. And we excluded all the preterm neonates with neurological impairment, congenital heart disease, critical illnesses, or on sedative medications. The equipment that we used was transcranial color Doppler ultrasonography machine, Sonocyte, and the parameters that we measured were taken before starting KMC, when the baby was in the supine position in radiant warm-up, at 60 minutes of KMC, and after 60 minutes of stopping KMC. The vital parameters that we monitored during this time was heart rate, oxygen saturation, and blood pressure, along with the cerebral blood flow parameters like peak systolic velocity, end diastolic velocity, mean velocity, resistive index, and pulsatility index. The preterm neonates stayed in the KMC position for a minimum of 60 minutes, and all the neonates were examined in a calm and resting state without any form of sedation. These are some of the pictures that we have taken. The first is during the KMC, and this is 60 minutes after stopping KMC. For the statistical analysis, we have done descriptive statistics along with paired t-test, Pearson correlation coefficient, and the analysis was done using the Strata 14.2. A p-value of less than 0.05 was considered significant. For the results, total 152 preterm neonates were admitted in the NICU during the study duration, out of which 40 clinically stable preterm neonates were enrolled, depending on the inclusion and exclusion criteria. The baseline data, we can see that of the 40 neonates, 24, that is 60%, were male, with the mean birth weight of 1.6 kg and the postnatal age of 6.8 days. Of them, 67.5% were appropriate for gestational age, while 27.5% were small for gestational age. And the mean gestational age was 33.05 weeks plus minus 1.6. Here in the box plot, we can see the peak systolic velocity and the end diastolic velocity. First, we can see that as compared to the before KMC, the peak systolic velocity has increased at the time where KMC was given. And again, after 60 minutes of stopping KMC, the peak systolic velocity has again reduced. And this was statistically significant. In the second box plot, we can see that the end diastolic velocity again has increased from baseline, which was before KMC was started, as compared to when KMC was being given, and again has reduced to after KMC had been stopped. Both of this data was statistically significant. Similar results were observed when we measured the mean velocity of the middle cerebral artery with increased velocity during KMC as compared to before and after stopping. Here we have the box plots for resistive index and the pulsatility index, which we have seen that there is significant decrease in the resistive index when KMC was started as compared to before KMC. However, after stopping KMC, no such significant difference was seen, and this data was not statistically significant. Now we have also seen the correlation of cerebral blood flow parameters of the middle cerebral artery Doppler with the gestational age and birth weight. We can see that with the increase in the gestational age, there is increase in the end diastolic velocity, mean velocity, and simultaneous decrease in the resistive index and the pulsatility index. However, no such significant change was observed in the peak systolic velocity. We also observed that with the increase in the birth weight, there is increase in the peak systolic velocity, end diastolic velocity, mean velocity, and simultaneous decrease in the resistive index and the pulsatility index. And all these data were statistically significant. We also compared physiological parameters at the baseline at 60 minutes of KMC and post 60 minutes of KMC. We found that the mean heart rate reduced when KMC was being given as compared to before KMC, and also it increased post 60 minutes of stopping KMC as compared to when KMC was given, and both of these were statistically significant. Similar results were seen in the oxygen saturations. In the mean blood pressure, we can see that the mean pressure has increased while KMC was being given as compared to baseline, and it also increased post 60 minutes of stopping KMC. However, the post 60 minutes KMC data is not statistically significant. We concluded that KMC improves cerebral hemodynamic response by improving the cerebral blood flow in clinically and hemodynamically stable preterm neonates. It also stabilizes the cardiorespiratory parameters, but further research on the effect of KMC on cerebral blood flow Doppler parameters is needed. The limitations of this study was the prerequisite of hemodynamic stability limited the application of KMC in the lower gestational age, and relatively small sample size was there in this study, and it requires great expertise to measure the MCA Doppler cerebral blood flow parameters. And in this study, we have not done the long-term neurodevelopmental assessment. Thank you.
Thank you. So you mean that after giving this KMC, there is increased blood flow?
Yes.
Right? So what is the clinical significance of this study?
This has improved the cerebral vasculature and blood flow, which right now only a few studies are there. But sir, as for the significance, it has improved, which can be responsible for long-term better neurodevelopmental outcome. But for that, research has still to be done. But this was the first phase, and we observed that the cerebral blood flow has increased as compared to the baseline.
Then what you have gained, what thing you have gained from your study? For the general message, what will you give to doing the study? What message you want to give by doing this study?
So that KMC is helpful.
Everybody knows.
Yes.
That. Everybody knows
But
to all.
Yes, they have so many benefits.
Every aspect of the life.
Yes.
So what you extra benefit you have gained by doing this study?
So this is kind of a phase one of the long-term study that we are planning. We are planning on doing long-term neurodevelopment scoring for these patients who have received KMC in the first phase. This is the first kind of phase of where we have seen that the cerebral blood flow parameters have improved during KMC. And then we would be doing the long-term neurodevelopmental outcome as well.
So as per you, the process is going on, not yet completed.
Yes, but this was the part one. Yes.
Study.
Pioneering.
Huh?
Pioneering.
So this was your.
आप आ जाओ ना इधर.
ना अभी नहीं आ सकते. इसके बाद बुलाएंगे.
Next, endotracheal intubation in neonates.
Yes, sir.
ये आपने इसको पहले ही कर दिया.
कर दिया? नहीं.
आपने उसको समझ के चल गए.
नहीं, I have cut down.
थोड़ा कम.
So I'll start.
Yeah.
Just let us start. Or do you want some break so that we can include somebody?
No, sir, I'm okay.
She want to complete.
Say Sara was
ब्रेकफास्ट जाना
She want to come. No, he will stay there. I will. Next study will.
okay.
The title of the third paper is Endotracheal Intubation in Neonates, and this was a prospective observational study. We all know that endotracheal intubation is a time-sensitive resuscitative procedure which is essential for the ventilation of neonate, but it is associated with a high risk of complications. And it is also a fundamental skill in which every pediatrician should be thoroughly trained in. But the adverse effects which occur during the endotracheal tube intubation have not thoroughly been investigated. Hence, we thought the need to conduct this study. The aims of the study were to evaluate the success rate and duration of intubation attempts in relation to the place and person, and also to analyze the adverse events that were associated during the endotracheal tube intubation, and to identify potentially modifiable factors which were associated with the adverse events. The study site was the level 3 NICU of a university affiliated teaching institute over a duration of 6 months. We included all the neonates in NICU or in the emergency which needed endotracheal intubation, and we excluded those endotracheal intubation events when no person was available to take a video. The institutional ethics committee had approved of this study. 75 neonates during the study period required endotracheal tube intubation, out of which 64 were analyzed, 11 were excluded depending on the exclusion criteria. Adverse events during the endotracheal tube intubation were classified into severe and non-severe. Severe comprising of cardiac arrest, esophageal intubation with delayed recognition, emesis with aspiration, pneumothorax, pneumomediastinum, bradycardia or hypoxia. Non-severe adverse events were bronchial intubation, esophageal intubation with immediate recognition, emesis without aspiration, and local trauma. The intubation guidelines were prepared based on the unit's policy, and the procedure had been continuously monitored by video from the mobile that recorded the intubation procedure along with the newborn and pulse oximeter. For the analysis, we divided the intubating people into 3 groups. First group being the first-year residents, second group of the second and third-year residents, and third comprising of the neonatal fellows and consultants. These are screenshots of various videos that we had taken during the study. The data that we recorded during the study was number of intubation attempts, experience of the intubating person, time to intubate successfully, cause of failure for intubation, and vital parameters like heart rate and saturation. And during the study, we also took in-depth interview of all the people that were involved in the intubation process after individual intubation. For the statistical analysis, we used descriptive analysis, chi-square test or Fisher-Exact test, and a p-value of less than 0.05 was considered statistically significant. Here in the results, we can see this is the chart showing success rate in the first attempt. Here for the first year residents, it was 31% in the first attempt of endotracheal tube intubation, which increased to 93% in the second and third year residents, and 95% for the fellow and consultant group. And this data was statistically significant. Here we observe that with the increase in experience, there is increased success of the first attempt endotracheal tube intubation. In the second chart, we can see we have plotted time taken for all the attempts against the intubating person. Here, the mean time for the first year residents was 79 seconds, which reduced to almost half in the fellow and consultant group. That was 42 seconds. The mean time for endotracheal tube intubation was 54 overall for all the 2 groups. And this data was statistically significant, and we observed that lesser time for endotracheal tube intubation was taken with the increased experience. Here we have chart showing the relation of time taken for the first attempt and the intubating person. Here we have divided into 2 groups, that is first attempt within 30 seconds and first attempt requiring more than 30 seconds. We observed that even with more experience, only 26% were able to intubate within the 30 seconds. That is the recommended time according to the NRP 8th edition. And more people had required more than 30 seconds for the first attempt. Here we have a pie diagram showing the first endotracheal tube attempt success rate along with the SpO2. The pre-intubation SpO2 more than 90%, 54%
success rate was there for the first attempt endotracheal tube intubation as compared to less than 90%. And this data was also statistically significant. Here we have a chart showing the adverse events that took place during the tracheal intubation during the first attempt and the intubating person. For the first year residents, severe adverse events were more common as compared to non-severe, and with the increased experience, the severe adverse events have reduced. The p-value is statistically significant. Here we can see that more number of severe adverse events take place with the R1, that was 35% as compared to the second and third year residents, that were 18.7%, compared to the fellow group, that was 6.3%. Here is a pie diagram showing all the various tracheal intubation adverse events that we faced. About 43.9% of the events had no adverse events, and for the most common was 20.3%, that was hypoxia and bradycardia that we observed, followed by pain and agitation of the newborn. This is the chart showing the problems that we faced during intubation, which we concluded by the detailed interviews of all the intubating person. We observed that large size endotracheal tube SpO2 probe problems, non-visualization of the vocal cord, secretions, performance pressure, laryngoscope problems, agitated newborn, and anxiety were some of the factors that hampered proper endotracheal tube intubation. We concluded with more experience, first attempt success rate increased with shorter duration of intubation procedure. But we also observed that even in the experienced hand, it frequently took more than 30 seconds for a successful intubation. And adverse events like oxygen desaturation, which was observed in 20.3% of the total intubations, was most common. And it was more common when performed by resident doctors as compared to the consultants. The limitations of the study was this was a single center study, so it does not reflect the outcome and practice of other setups, and we did not use protective practice measures like paralytic pre-medication during the intubation procedure, so this might affect the result. And since this was an observational study, we can only show associations and not causality. Thank you.
Thank you. So you said that in the first year, the time was around 80 seconds, 79 seconds, right? Was there any protocol? You said that
Yes,
the time limitation is 30 seconds as per the NRP India and 836, right?
Yes.
So was there any protocol?
Sir, we have our units policy for the intubation protocols. Though the time limit is 30 seconds, we did simultaneous SpO2 and heart rate monitoring. If the saturation was more than 90 seconds, then we went for a complete successful attempt, even if it took more than 30 seconds. But if the patient,
the bag and mask ventilation,
we have kept everything ready. First, we stabilized the baby to a pre-intubation saturation more than 90%. Then only the intubation attempt was made. And during the intubation time also, if there was any episode of hypoxia, we would discontinue the intubation process and take the baby on bag and mask ventilation.
Okay. So do you think by this study, do you think that the video laryngoscope we used in neonatal period? Is there any study to favor that?
Have the study regarding? You have not studied.
Sir, I'm not aware.
Video laryngoscope.
That is one of the methods that could be done, but about the studies, I'm not.
Not right.
What's your time to intubate?
Sir, it depends on the baby, but it usually is less than 30 seconds from what I have experienced.
Okay. How many baby have you intubated?
During my residency, it would have been like more than 500.
More than 500
During my residency, yeah.
Sir.
3 years.
Out of how much delivery?
No. So what is the incidence of intubation? If you talk about the neonatal resuscitation,
That's
what
not too
percentage
much.
of the baby will require
Sir,
resuscitation?
I'm talking about the cumulative 4 years that I have worked.
How many years?
NHB included.
No. How many years you have studied and done this?
So this was a 6-month study.
6 months. No. You have done 500 in how many?
So 4 years.
4 years.
Yes.
500.
500.
Almost like.
Around bag and mask?
Sir, mine was a government hospital. So we
I
had.
know that. I'm
yeah.
also working in government hospital. Okay, fine. Okay.
Okay, no.
Thank you, sir.
So I just wanted to share that this centrifugal tube, there's a paper that was done long time back.
सिंपल बड़ा फायदा आपको अच्छा लगता है नहीं सर आपको लगता है
Thank you, sir.
Next one is Dr. Fatima.
Dr. Fatima. Hi. Cross.
Next
Fatima.
one is Pratima Anand.
Pratima must be online. She's from Delhi, Safdarjung.
नहीं वो तो है लेकिन इसका ऑनलाइन का कुछ है
और ऑनलाइन है लगे हुए थे
हाँ प्रियंका.
ना प्रियंका is there but just check now if she's online. She might be online. ना वही हुआ ना ITMC वाला पेपर
नहीं इसमें कहाँ है क्या है वो रैम्स कैनुला और उसके पास वो दोनों टीचर एंड फैकल्टी वाला
Pratima is not joined.
Who is joining? Priyanka.
Priyanka is not there in this group.
Ana Onu. Call Onu.
No, Anu is not also not there. Anu कहाँ है?
तो Onu joining.
वो दूसरे जगह है.
No, is not joined.
Fatima Anand is there or not?
I don't see it. I can't see it.
आप इधर से बात करो.
सर लैपटॉप आ गया.
तुम ये देखो पार्टिसिपेंट्स में देखो
प्रतिमा है. इस प्रतिमा ज्वाइन
सर नहीं है.
नहीं है.
फोन करके पूछो मैसेज.
दूसरा नेक्स्ट करवा देते हैं. प्रतिमा को ज्वाइन करना था ना.
Want to ask her?
You can ask. Next.
Only this much others.
Can you use for Safdarjung?
Fatima है नहीं है ना.
फातिमा नहीं इसमें कोई
सपनिक to call Sapnik.
सपनिक है इसमें.
हाँ ये Sapnik. Sapnik Khandal पे.
Hello.
Hello. Yes, sir.
Sapnik, are you there?
Yes, sir. I am here.
Okay, you can start your presentation.
Your time is.
You first share your screen.
Okay. Are my slides visible, sir?
Yeah.
Your slides are visible and you are also audible. So now you can start.
Time.
Shall I start, sir?
Yeah, you may start.
6 minutes.
Good morning, all. Today, my study is about looking at the risk factors and outcomes of CLABSI in neonates. It's a case control study. So coming to the introduction, we all know that infection is one of the most important reasons for the neonatal mortality and morbidity worldwide. And central line associated bloodstream infection is one of the most common healthcare associated infections in neonates. And we know that healthcare associated infections are largely preventable. Cornerstone of any infection control would be to understand the risk factors associated with it. So in our study, we aimed at looking at and outcomes associated with central line associated bloodstream infection. So my research question was, what are the risk factors for CLABSI among neonates with central lines? So the objective was to determine the risk factors for CLABSI in neonates in a tertiary care NICU, and the secondary objectives were to describe the organisms causing CLABSI in our setup and to compare the outcomes between the neonates with CLABSI to those without CLABSI. It was done in a tertiary care NICU. The time period from June 2019 to February 2021. The type of study is a case control study. The cases are those neonates with CLABSI, and the controls are those neonates with central lines but without CLABSI. So we arrived at a sample size of 34 by assuming the odds ratio to be 4.2 based on the study by Woods et al. With a power of 80% and the confidence interval of 95%. So the definition used for defining CLABSI was that there should be a lab confirmed bloodstream infection in the presence of a central line or within 48 hours of the line removal. And the data sources, regarding the data sources, the hospital infection control committee, we have been collecting infection control statistics since the last 8 years, which included various parameters like the rates of WAP, CLABSI, BSI, antibiotic days, mortality, morbidity. Our main data sources are HIV history and National Neonatal Perinatal Database. So coming to the selection of cases and controls, the case are those CLABSI cases that occurred between the period of June 2019 to February 2021. And for each case, we identified a control from the same month as the case without having CLABSI but having a central line. And the risk factors and outcomes studied were risk factors, gestational age, birth weight, number of lines, and number of central line days. And the outcomes studied were discharge, diagnosis, medical advice, death, duration of hospital stay, any respiratory or CNS morbidity. The continuous variables were analyzed using chi-square official exact test, and the continuous variables are analyzed using t-test. So coming to the stroke chart, a total number of babies with central lines were 270 during the study period, and total number of CLABSI cases identified during this period were 34, and the controls were identified were 34. So the total number of the neonates recruited was 68. Coming to the demographic data, as we can see that in the birth weight, gestation, and gender, the p-value was not significant between the both the groups of CLABSI and no CLABSI. Coming to the number of central line days, the average number of central line days for cases is 12.4 days, whereas for the controls is 8.3 days, and the p-value was significant, 0.02. And the number of lines was also not significant. The morbidities, coming to the morbidities, there is no much significant difference between the CLABSI group and no CLABSI group in terms of oxygen requirement, respiratory morbidity, and CNS morbidity. Coming to the electrolyte imbalances and blood transfusions, both were found to be significantly different between cases and controls. The cases having higher incidence of electrolyte imbalances and blood transfusions. The outcome studied, the death and discharge against medical advice, there is no significant difference between the cases and controls, p-value being insignificant, and the duration of hospital stay was significantly different between the cases and controls. And the causative agents identified, most common causative agent we identified in our setup was cons, followed by Klebsiella and Enterococci. The limitations of my study are it's a retrospective study, and many of the factors which may have effect on the CLABSI incidents, like the scrub the hub time, number of central line breaches, compliance to hand hygiene, were not taken into the account. So the final conclusion of my study, the main risk factor we found was that CLABSI was the duration of central lines was a significant risk factor. And main outcome of a CLABSI found was that it increases the duration of hospital stay. Thank you.
Thank you, Dr.
Sir.
Good study. Don't you think that the weight and this gestation was on the higher side for this baby? Because majority of the baby which require the central line are on the lower side.
Yes, sir. The majority of the babies who require central lines would be VLBW babies or LBW babies. In our case, we did not find much difference between the cases and controls in terms of gestation as well as the birth weight.
Okay. So what could be the reason of the electrolyte imbalance?
So probable reason is an association, sir. It is not probably the more baby has electrolyte imbalances, they need more number of corrections, and like in terms of any electrolyte imbalances need correction means that might require a longer duration of central lines, like that it can be.
I think it was, you said there was no difference in the number of lines. Can you explain
Number of lines, yes, sir.
more, yes, the lines was, there was a difference, but there was no difference with the number of lines. What was the usual number of lines which were put in the cases in the control? There were more than 1, 2, 3 lines, or what? What are what umbilical, arterial, venous, or the PIC lines?
So we have taken into account both the PIC lines, umbilical lines, UVC, UAC, sir, or any surgical central line also. So that did not find any difference between the number of lines. So the in the cases, the usual number of lines we found was 1.7 lines, and controls 1.6 lines.
Oh,
There's
there
no
hardly any difference.
Thank you. Thank you.
Thank you, sir.
Anyone left? क्या नाम? विवेक कुमार है?
अपडेट हो रहा है, आई कैन प्रेजेंट आफ्टर।
अच्छा,
किससे बात करो रहे?
किरण कुमार हरिदास, growth pattern of preterm babies. Okay. You are from
Tamil Nadu.
Tamil Nadu. Government college or yeah,
Government college, sir.
which area?
Chengalpattu.
Your number is 12.
Yes, sir.
Yes. You will get 6 minutes.
Yes, sir.
This is the laptop. The last 2 to 3. Close for me.
आप लोग चले गए क्या? वो प्रेजेंट करके चले गए?
व्यक्ति उसे बैठे
Slide mode. Yeah. Will you start now?
Yes, once.
Your time starts now.
Okay. Good morning,
10,
respected
27.
judges. Thanks. I'm Dr. Kiran. I'm here to present my research paper, the title of which is Growth Pattern of Preterm Babies Less than 34 Weeks of Gestational Age in a Tertiary Care Hospital. Retrospective study. Starting with the introduction, growth of preterm neonates has a short and long-term implications. The gold standard for postnatal growth is intrauterine growth. Monitoring is essential to identify any deviation from the normal pattern. And the extrauterine growth retardation restriction proportion in Vermont Oxford network cohort was around 50.3%. The NICHD study also showed that there are some nutritional deficits persists during the hospital stay, and those with complications have slower growth. With this background, we aim to assess the growth pattern of our babies who are born less than 34 weeks of gestational age using the interval 21st growth charts. Methodology. It is a retrospective cohort study conducted over a period of 1 year between January and December 2019. The study population included babies who are born less than 34 weeks of gestational age. It is studied in our medical college. Inclusion criteria: infants born with gestational age of less than 34 weeks and with a duration of hospital stay for more than 14 days were included. Exclusion criteria: infants born with major congenital anomalies or suspected chromosomal anomaly or syndromes. and infants transferred to other hospital. Infants died during hospitalization were excluded from the study. These are the major definitions we used in our study. AGA more than minus 1.28 and less than plus 1.28. SGA less than or equal to minus 1.28 SB. LGA more than or equal to minus, plus 1.28. And extraterritorial growth restriction UGR was less than or equal to minus 2 SD. During our study period, we had 433 babies who were born less than 34 weeks of gestational age. Among them, we excluded 315 babies based on our exclusion criteria. We enrolled 118 babies, of whom we collected the details and we analyzed. The most common mode of delivery in our population was vaginal. That is 61% of the babies were born through vaginal delivery. The most common preterm phenotype was spontaneous preterm labor, and remaining were PPRN leading to premature delivery and indicated preterms. The antenatal steroid coverage in our population was nearly 88%, at least with minimum 1 dose of antenatal steroid. These are the antenatal characters. The obstetric index, 60% were primary and 40% were multis. The most common complication we identified in antenatal population was gestational hypertension. This is the gender distribution of our babies. There was almost no difference in the gender. 50% were male and 49% were female. This is the growth status at birth according to gestation. We used intergrowth growth charts. 80% were AGA and 15% were SGA. Weight at birth and discharge. The mean birth weight of babies at birth was 1,600 grams, and at discharge it was 1,700 grams. The mean gestational age at birth was 31 weeks. The discharge gestational age 35 weeks. The growth status at discharge. At discharge, our babies remained AGA around 60%, and around 40% of the babies they went in for UGR. This is the growth status at discharge according to birth status, that is the AGA babies and SGA babies. AGA babies, around 67% of the babies remained AGA, whereas 32% of the AGA babies had extraterritorial growth restriction, and SGA babies, nearly almost all the babies remained UGR, and only one baby was falling in the category of AGA at the time of discharge. These are the birth weight scores for the UGR and no UGR babies. This is the mean scores. For UGR babies, the mean score at birth was minus 1.15, and at discharge it was minus 2.27. There is almost a 1 standard deviation growth fall. And in those babies who are not found to be UGR at the time of discharge, the mean birth score was in the positive side, that is 0.13. And at the time of discharge, it was minus 1.06. It was around 0.6 fall in the growth from birth to discharge. This is the duration of stay in the hospital and time to reach full feeds. Those babies who were UGR, the duration of hospital stay was around 27 days, and time to reach full feeds, that is considering 150 ml per kg per day, was around 10 days. Whereas those babies who did not have extraterritorial growth restriction, the duration of stay was less, that is 23% compared to UGR group, and the time to reach full feed was around 8.5 days. These are the complication rates between the AGA and SGA babies at the time of birth. The most common complications identified in AGA babies were requiring respiratory support and having respiratory distress syndrome. And the next three are the complications which are found most commonly in SGA babies, that is requiring antibiotics, requiring inotropes, and having apnea. I'm just quoting here two studies where they also found that Assembly et al. Published in 2018, 45% of the babies of UGR was there. And another study, Sumru et al. 2017, they had around 37% as only 1 minute left. Yes, 37% as UGR. In our study also, we had 39% as UGR. Concluding this, there is significant proportion of UGR in our study population. It is difficult to achieve intrauterine growth standards postnatally. The growth rate is hampered by postnatal complications in preterms. With our study, we just want to recommend that to achieve intrauterine growth pattern, aggressive neonatal strategies in preterm are necessary. Early diagnosis and treatment of preterm complications should be done to avoid growth failure. These are my references. Thanks.
Thank you. Thank you. Thank you, Krishna Kumar. Thank you. So you mentioned about the intergrowth chart.
Yes, sir.
So
Yes.
what was the subject included in that intergrowth? I think originally only the breastfed baby was included.
Yes, sir.
And what was the feeding pattern in your study, in your section?
Actually, all those feeding patterns. Those AGA babies who are born less than 1.5 kgs, we start with 30 ml per kg of feeding and 50 ml per kg of fluids, sir. So initially, sir. So once they tolerate feeding of 30 ml per kg, we increase the feeding by around 30 to 35 ml per kg per day, sir.
And
That is
milk
our
was the mother's own milk or?
mother's own milk, sir. If not available, we have a milk bank, sir. We use donor human milk, sir.
Kiran,
Yes, sir.
your criteria was while you're showing the pictures of male-female distribution, the figures shows actually quite a difference. But when there was no significant difference, as you said,
Yes,
because
50% was male and
49,
yeah.
but the figure was so different. Why were you putting such a figure? It shows actually like a very different thing also. And your stay again, what was the significant difference between the duration of stay and the time to reach full feed? Because you showed the photograph
Yes, sir.
where there was some difference,
Yes,
but whether it was significant because the number seems very close.
Yeah,
23,
they look close, sir, actually.
23 and 27,
Yes, sir.
8.5 and 10.4.
Yes, sir.
Whether there was a significant difference or not, because that star I am not looking at.
Yes. So actually, we are presenting only the proportions, sir. We actually did not apply the statistics here.
You have applied or not applied?
Not applied for this.
You have compared to why are you not applying the statistics
Yes,
between
we
the two
have.
groups?
We just wanted to know the proportions, sir, why it has happened, why the complications are happening.
You have not compared because there is
No. Yes.
whether there was a significant difference between the two groups or not.
Only the proportion is looking different, sir.
Okay, good. Okay.
Is that to make
Okay.
it-
Thank you.
Thank you, thank you. You want to?
No. Is there- Anyone left except him?
That's good, we have finished. Huh?
We have finished.
Valentine.
वो आए नहीं यार, यहाँ आके दरवाजा साफ
विवेक कुमार।
सब सारा
Yes.
सुबह वाले का ये दिक्कत होता है 3 बजे वाले दिक्कत नहीं होगी we have to do at 3 o'clock. You will be there at 3 o'clock also? The other team is there. You should be. You know how to do it.
Yeah, you should be there. Actually, I'll be there, but this will be judging na at that time.
दादा आपको फोटो देना मुझे बहुत सारी फोटो आपके पास
अभी फोटो हुआ क्या? हो गया इसमें?
शेयर माय वीडियो.
We have clicked those वगैरह सर के फोन में बहुत सारी फोटो है.
हाँ, अभी इधर आ जाओ. अभी ये वाला फोटो लेना है लगा लगा के साथ.
कौन है?
हाँ ले ले.
तुम इधर आ जाओ। तुम इधर आ जाओ। तुम इधर आ
बच्चे
जाओ।
और जोश जिसने प्रेजेंट किया वो इधर आ जाओ.
आ जाओ आ जाओ आ जाओ।
तो इसका हुआ पहले इसका हो रहा है.
हाँ, आ जाओ।
विवेक का है ना, विवेक यू मेट यस्टरडे ना.
चलो इधर आ जाओ।
इससे पहले विवेक का फोटो खींचते हैं. इसको बंद कर सकते हैं फिर.
ये तुम इधर बैठ।
आ जाओ बच्चे. कम We are only taking photos.
मेरा
Only Vivek left ना.
विवेक बंगाली विवेक
No, sir.
He's not Bengali.
no विवेक
Vivek is
Antaratma.
Bengali. Vivek is not.
Vivek is
अंतप
intelligence. Buddhi Vivek type. Something like that.
ना ये conscious
Conscious. Yeah.
ये conscious what you
I will listen to you.
10:37
Time.
So Dr. Kiran has already talked about growth. So I will also talk slightly more about it. So we did a study of body composition in preterm very low birth weight infants fed unfortified breast milk compared to fortified breast milk. So it all started with this baby when we found this on a round, and we realized the baby was quite chubby, but we were doing everything right, and we were giving fortification as is our practice. And then we tried to monitor the baby. We then realized that we had actually had no consensus on how to actually monitor and what is the ideal preterm growth.
And even though we use fortification widely, and which is currently standard of care in developed countries and even widely used in India, WHO feeding guidelines and NNF do not routinely recommend. So we all know about fortification, that fortification leads to higher growth rate and which might lead to better neurodevelopmental outcomes, and maybe some other pathways also it might lead to better neurodevelopmental outcomes. But what we actually don't know is what is the quality of that weight gain. What is the quality of weight gain which might lead to that better neurodevelopmental outcomes. And further, we know that there is not enough evidence regarding better neurodevelopmental outcomes of fortification. And further, there is rising concerns regarding extra fat deposition, which might occur with fortification and which has implications of metabolic syndrome in adult life. So recently, AAP has also recommended that body composition should be offered whenever possible to measure actually the quality of weight gain, the quality of growth of the baby rather than just anthropometry. So based on this, we realized that we don't know actually whether the short-term growth is fat or fat-free mass. And even in those who are giving unfortified breast milk, what is the body composition of these preterm babies at term, and whether there is any difference between the fortified group and unfortified breast milk group. So with this, we hypothesized that giving 180 ml per kg with fortification versus 200 ml per kg, is slightly higher volume and increased up to 220 ml per kg unfortified breast milk, might lead from becoming this to becoming this, with a decrease in body fat percentage of around 20% among 28 to 34 weeks VLBW infants at 40 weeks of PMA. Same can be expressed more scientifically in this way. And our primary objective was to compare the fat mass percentage, fat mass, and fat-free mass. And secondary objectives were to compare the anthropometry, weight, length, head circumference, and look for the safety of high enteral feeding volume via complications. So body composition was assessed at 40 plus minus 1 weeks in terms of fat mass percentage, fat mass, and fat-free mass. Weight we measured every alternate day as is our NICU policy, length weekly and head circumference weekly. In hospital complications, feed intolerance, and ECS, these were measured. And on follow-up, we measured anthropometry and ROB status of the baby. So this was done in a level 3 NICU of AIMS, 12 months duration, Jan 2020-21. And we applied a stratified block randomization of AGA-SGA. So we included babies of 28 to 34 weeks, less than 1500 grams, who were receiving at least 120 ml per kg of oral feeds, of which at least 75% should have been the mother's own milk. We excluded babies who were having major congenital anomalies, eye drops, or if the mother's EVM could not reach 75% by day 14 of life. Ethics approval were taken. We did a CTR registration and consent were taken. So in fortified group, we gave 180 ml per kg of feeds volume with 1 gram of per 25 ml of P9, as is the standard recommendations. And unfortified group, we gave 220 ml per kg, which was hiked up to 220 ml per kg in case of inadequate weight gain of less than 15 grams per kg per day for 1 week. And we added multivitamins. We made a detailed SOP regarding when to do what and put it on our nursery so that each one knows and follows the same. Body composition was assessed via this Peapod machine, which we have next to our nursery in our endo unit, where it took around 7 minutes for the transport of the baby and around 30 seconds for weighing, and including volume measurement around 2 to 3 minutes. Total repeated twice. It took around 15 to 20 minutes for the total test. And the baby was monitored throughout the test via this transparent glass, so that in case there was any issues, we can stop the test. Quality check was done as we had taken 2 readings, and if the difference was more than 2%, then we took a 3rd reading. Average of the closest 2 were taken, and the machine was calibrated weekly by the technician and before each test by the investigator. Post-discharge follow-up, we gave actually pregnant fortification from our NICU to parents so that they don't have to buy 2 weekly supply, and they were encouraged to note down the milk volume. In unfortified group, they were supplements were given and they were encouraged to note down the volume. Compliance chart was given so that they can write down, and we saw that on follow-ups. We applied per protocol intention to treat analysis and also did a sensitivity analysis to look for between the missing and non-missing groups. Sample size calculated based on the 0.5% standard deviation at 2.2 was 63 per group. So what we found, among the 108 neonates which were enrolled, we enrolled 48, 37 were excluded and 23 was not eligible. Out of these 48, 22 were in unfortified group and 26 were in the fortified group. out of which we could analyze 11 at 40 weeks in unfortified and 17 in fortified group. Baseline characteristics of those babies enrolled were quite similar, except for there were slightly more males in the fortified group. Otherwise, almost all baseline characteristics were similar between the groups, with gestation of around 30 and birth weight of around 1.1 kg. So what we found was that among the 11 unfortified and 17 fortified, the fat mass percentage was 23.5% in unfortified group compared to 18.1 in fortified group. Time over. So and the fat mass percentage and fat free mass was not different. In predictors, male and postnatal age were slightly more predictive, and there's slightly less in hospital weight gain of 16 gram in unfortified group. 2 point. There was no differences in feed intolerance, other morbidities, and 3 babies required crossover. And this is the intergrowth body composition norms. We see that our babies were slightly at the higher centiles of more than 97 percentile, both males and females, compared to the Western data. So this was the first study evaluating the body compositions, and we took a detailed intake assessment of the babies, and it adds to the limited pool of data assessing the effect of fortification. However, because of COVID, many babies we missed and we could not complete our sample size, and the exact postnatal discharge nutritional intake we could not assess for that. So we conclude that the fat mass percentage was around 20.2% in babies at 40 weeks, and due to limited sample size, though, so we cannot make any conclusive comparisons. And though this air displacement plethysmography is very safe and feasible and can be applied in preterm infants, which can act as a measure of quality of growth of preterm infants rather than just growth. And I would like to thank all the nurses, families, and babies for participating in this service. Thank you.
Okay, thank you. So we are not going to ask questions because we have already taken that time.
Just so, I was not given 1 minute of warning. So
just 1 minute. You did per protocol. Why not intention-to-treat analysis?
Sir, we had three
because of the number of.
Yes, we had very small number actually. So we wanted to be sure.
Okay.
Okay, thank you.
Port बहुत कॉमन हो गया है
थोड़ी कॉस्टली है
कोई पेशेंट को जो उधर ले गया तो हाइपोथर्मिया तो नहीं
सर वही था वी मेजर्ड टेंपरेचर ड्यूरिंग and most of the babies came from actually home, so they were already well flown.
The problem with P-Pod is that it does not measure the components of the fat sheet.
It is a two-component model.
This is very similar to yours. So we have a total body potassium chamber,
okay,
which is similar to P-Pod. So my studies P-Pod versus total body potassium chamber, which actually measures in the fat-free mass how much of water, muscle mass, as well as other components.
Yes, sir. Great, Vedanta.
Everything else can follow. 40 weeks they had to come. So
So we have a total body potassium chamber that is for 2 years now. So we are using total body potassium chamber more than before. A lot of research centers are using
Sir? Hello? Good morning, sir. Yeah, like I'm Dr. Anjali, and this paper presentation slot was between 10 to 12 for me.
10 to 12?
So,
yeah.
In which hall?
In which hall? In this hall only? But this slot is between 8 to 10 only, right, Harshita?
This is your name is not in that list.
Okay, so I should.
Your is slot number 2, 10 to 12.
And where is it, sir? It is hall 8. 10 to...
Hello, you are not in this hall.
So you should have helped
that will be next batch. Next batch. Please wait for the next batch.
Please wait.
Yeah, you have to wait. Organizer will come and let you in. right?
Thank
This
you.
is
So
this.
should I log out now? Okay.
No, you make it
log out.
You keep on login. You
Log
keep
in.
in login.
Okay.
Under mute.
Okay.
Okay, sir. Thank you.
Do mute.
Anjali, this was 8 to 10. 10 o'clock now, next session.
तुम्हारे दोस्त है.
हाँ, हाँ, my God.
So you should have helped, na? The people over here.
You can just talk in that mic.
Hello, Anjali. 8 to 10 it was. Just now 10 o'clock thing. 8 to 10 has got over. 10 o'clock is not yet started. Heard? Huh?
He's on mute.
You heard, no, Anjali? I think so.
So 10 o'clock, one more session is there, no?
Yeah.
Who will be
10 to 2
the
or 10 to 12?
10 to 12.
10 to 12? So who will be taking, no? Judges? No, judges.
We don't know the judges' grade.
नहीं वो कौन से एड्रेस पे ले गया है, कौन से एड्रेस पे ले गया है, एलपीजी मेडिकल कॉलेज से ले गया है। मैं आपको कोरियर मेल का एड्रेस वो कांटेक्ट नंबर सेंड कर रहा हूँ, तो रिसीव नहीं कर रहा है, ठीक है? हाँ, मैं इमीडिएटली हाँ
This one is found on one. Let's see, confirm. Just confirm. Thank you. Thank you.
Most of the venues are empty, huh? Yeah, most of the venues are empty. Now, there was paper session in the morning. Okay, here. Yeah. But I didn't see any person. What is the trading session? There is no trading session. There is trade counter. It is not allowed. No, it's allowed. There is inside one more hall is there. There is inside is another hall. There is one more hall. And there is bigger one hall is there. Hall A. And after we walk straight down there towards swimming pool and all, there is one more hall. I think B and C is there. And along with that, there is exhibition center. So exhibition center is there. Yeah. And also the in fact refreshment, tea, coffee. Yeah, they are only, sir. So that exhibition center. Yeah, yes, sir. That exhibition center. Nearby exhibition. Display is not proper. Yeah, display is not at all proper, sir. And there should be big display, huh? No, they have no actually. From first day, I am also coming from another place. You are coming from? Sir, I came from Delhi. Delhi. I came from Calcutta. Yeah. I think anyhow that it is when we have made it in hybrid form, those who are coming, at least. No, they have not considered anything like one like transportation is a problem. It's a too long. It is too far away from the almost 40 kilometers from the more than that. Yes. In fact, 80 kilometers from the airport. Yes. It's almost 50 to 60 kilometers from the airport. They should have made some arrangement. Yes. No, this is not proper. No. It's like first they I have spent a lot of money to reach here. And also you see the quality of the nothing kit. Yeah. Like just the thaila they are given. No, it's not proper. It should be at least up to the month. Yeah. We have not seen anything like that. No. Prior they have like good bags and everything. No, I attended so many, almost each and every Neocon, and this is a very poor show. Was a very poor show. And if I made it even for the first day, I have make it completely virtual. Yes, yeah. On the first but you have taken money, no? Yeah, so on first day I have registered for the workshop, so I haven't been able to reach here physically. So they have started online virtual. Already they have started virtual workshop, but on the virtual workshop also the no video is running properly, and nothing was there. There is complete mess over there. Complete mess. Yes. It is you just staying here. Yes. And in fact, people come here for some academic fest. Yes. And academic fest, and at the same time some good meeting point. Yes. Most important is the good meeting point, and at least good and respectful facilities. Yes. Nothing is there. Your name, please. My name is Dr. Samir, sir. Dr. Samir Patil. Samir Patil. You are from Maharashtra. Yeah, basically from Maharashtra. I was doing my fellowship in Delhi, sir. Yeah, fellowship in your yes. In which country? Sir, it is in Fortis Laughing associated with but the tube is there. Fortis hospital tube is in respiratory medicine. Okay. Anyhow, because I am such a senior person, I've seen so many things. Yes, sir. I cannot. Well, they have done it. Okay, that place is good. No problem. We have spread everything. Yeah. Okay, but this place should be there. Some form of yes. And one, they should have some inquiry and some persons to help. Because no, you have to ask your colleagues on our documents. Yeah. Okay. Thank you, sir.
ಲೀವ್ ಕೊಡ್ಬೇಡ ಬಿಟ್ಬಿಡು ಸುಮ್ಮನೆ ಬಂದ್ರೆ ತೊಗೊಂಡ್ರೆ ನಾವು ಮಾತಾಡ್ತಾ ಇದ್ರೆ ಎಲ್ಲ ಅಡ್ಮಿನ್ ಮಾತಾಡ್ತಾ ಇದ್ದಾರೆ. ಇವಾಗ ವಾಯ್ಸ್ ಪಿಕ್ ಆಗ್ತಾ ಇದೆ.
ಮಮ್ಮಿನೂ ಅಂದ್ರು ಬಟ್ ಯಾವ ಎಲ್ಲವೂ ಟೈಟ್ ಹಾಕವ್ರಿ ಫೀಡಿಂಗ್ ಫ್ರೆಂಡ್ಲಿ ಇಲ್ಲ
What's the presentation? Online. 2:30 क्या? अपन Bangalore Neocon.
Certificate I just wish you so first you need one 2 posters and 1 paper. Probably another exams in handy.
ചേച്ചിയാ Oh, sir, like wheels.
Wheels. എത്ര ഈ ഒരു വർഷത്തിൽ എത്ര ടൈം വന്നിട്ടുണ്ട്?
ഒന്നോ രണ്ടോ ദിവസം വരാതിരുന്ന
വീട്ടിൽ പശുവെല്ലാം പശു ആനിമൽ അല്ല പട്ടി
ഉണ്ടോ? കുഞ്ഞുമായിട്ട് കളിക്കോ കുറെ?
അവരങ്ങനെ കളിക്കാറില്ല, അവര് പുറത്താണ്.
താഴെ ചുമവല്ല താഴെ ചുമ കൂടും.
मुश्किल से जिंदगी
Hello, good afternoon. Any idea where to join for poster presentation?
इसमें दो ही लोग हैं एक तू एक मैं और कोई नहीं और कोई नहीं हम दो ही हैं जो हमारे इस लिस्ट में जो है वो उनमें से कोई नहीं है अभी तक कोई नहीं है कितना देखिए हमारा फिर से मैं तुम्हारे साथ ही हूँ।
क्यों अभी जैसे तुमने आईडी वगैरह डाला तो कहाँ पे डाला नई नई वो लिंक खोल के ओपन करता था तो मैंने आपको ज्वाइन किया था आपका नेम पूछता था आपका नेम डाला आज जैसे हम इसको फिर से एक नया ब्लॉग ओपन करते हैं तो ये वीडियो तुम्हारी ऑन है अच्छा वीडियो और अब आपको दूसरा लिंक पे जाना है इसको छोड़ दो कहाँ था वो इस पे था ना इसको काटा कर लो इससे नया खोलना सर जो खोलना है उसको कॉपी कर लो ऊपर रख के और उसको डायरेक्ट अपने पिछला लीव हो जाएगा कॉपी कर रखा है नहीं वाला चीज जो ये वाला खुल रखा है ये चीज हमने कॉपी कर पेपर प्रेजेंटेशन 1 वाला चाहिए अच्छा कॉपी कर रखा है कंट्रोल सी दबा आप कहाँ से नया ब्राउज़र ओपन करेंगे इसको लीव करते हैं इसमें तो मैं ओपन अंदर जाना है
Who all are there? Can you just tell your numbers? Hello, can you just tell your numbers who are present online? Tanmesh Sahu. Tanmesh, what is your number? Who is Tanmesh Sahu? Can you hear me? And there is one Apple person also. Dr. Annu, what is your number? Annu?
Hello, sir. I am Dr. Krishna. My number is 38 OFP.
You are Krishna is which, what name is there? Apple.
Sorry, sir. I will change it.
Apple, acha.
Rename it.
Tappal, Skippa Mariam.
Hello,
Skippa
sir.
Mariam.
Hello, sir. I'm Shilpa Maranjon. I'm for online paper.
Hey, what number? What is your
378,
number?
sir. 378. 378.
378? No. कहाँ पे है? मरियम तो यहाँ पे नहीं है. Miriam is not in this hall.
Sir, it's for online paper poster presentation.
Oh.
Yeah. कुंदर silent होना है.
You are in the wrong room. ठीक है.
Can you please tell me the right one?
I don't know.
The lots of things are there. That's
Rajkumar Yadav.
Good afternoon, sir. Sir, my number is 39, sir. 39.
Yeah. Rakesh Reddy is there.
Hello.
Rakesh Reddy is there? No. Tanmesh Sahu. Who is Tanmesh Sahu?
Hello.
Arpita Kulshrestha.
So my number is OFP 47.
47 is not here. In this some other hall.
Okay, sir.
Okay, please just find the correct hall. No, Mohammed Jakiullah. Jagjit is not coming. Deepa Upasi. Deepa Upasi is not there. So Rakesh Reddy is not there. Who is Dr. Anu?
So she's there for the poster, she said, no?
She's a poster one. Yeah. Okay.
Let's start.
So we have first offline one, Preeti. Timer है. 6 minutes. The time is for 6 minutes. You can stand here. Others to keep their mic muted. Time. बाकी वो देखा है 6 minutes. Start. What is the name?
ಅದೇ ಅದೇ ಮೇಲೆ ಇದೆಲ್ಲ ಮೇಲೆ ಇದೆಲ್ಲ ಅದೇ
Hello.
Yes, sir.
Let's take it.
Yes, sir. Thank you. Good afternoon, sir. Good afternoon, everyone in the room. I'm Dr. Preeti. I'm presenting a paper presentation regarding implementation of delayed cord clamping in term infants as a quality improvement study done in a tertiary care hospital. The problem statement: in a tertiary care hospital in Chengalpattu with deliveries of 2,250 per year with level 2 NICU, we wanted to standardize the practice of delayed cord clamping. The frequency of delayed cord clamping in term units was identified as 44% at our hospital in August 2021 before the implementation of the program. Background: delayed cord clamping in term units is better, is proved to be better for maternal and neonatal outcomes by improving iron stores in the neonates and less number of hospital stay. And we wanted to assess the implementation of DCC as a quality improvement project. So, aim of the study is to study delayed cord clamping practices in term babies born by both vaginal delivery and cesarean section, and to increase the practice of delayed cord clamping for at least 1 minute after delivery from baseline of 44% that was present before the implementation of program to 100% within the next 4 weeks. Study setting was done in SRM Medical College and Hospital in Chennai, in the delivery area, both labor room and operation theatre. Baseline measurement: all interns and pediatric residents documented if delayed cord clamping of at least 60 seconds was done in the case sheet. They also documented if the procedure was being deferred. All babies screened at 72 hours of life for serum bilirubin and thyroid levels as per the unit policy, and need for phototherapy was used as a balancing factor for the study. Data collected from phototherapy register in NICU and postpartum hemorrhage rates was also collected from the OB-GYN registers. Methodology: baseline delayed cord clamping practices 4 weeks prior to quality improvement implementation were collected, which was 44% from the baseline. We formed a team comprising of a team leader and other members also, including the assistant associate professor in the NICU and one assistant professor from OB-GYN and one staff nurse from labor rooms. Methodology: flowchart of the delivery process and the fishbone analysis for leading to early cord clamping was analyzed, and possible solutions were implemented and tested in the Plan Do Study Act cycle that was conducted every 10 to 14 days, approximately for every 40 to 50 deliveries. This was the fishbone analysis which we came from. Initially, there was no existing policy, and there was no, many people were unaware of who were eligible for delayed cord clamping, and unaware of the technique and timing of delayed cord clamping. And the labor room staff were unaware. Failure to implement by OB-GYN and PEDS team in spite of the knowledge of delayed cord clamping with them. And everyone were unaware of where to place the baby post-delivery to do the delayed cord clamping, and how pediatricians will resuscitate if we are about to do delayed cord clamping. That's when the issue was, we were doing all early cord clamping initially before implementation of the program. So this is what is happening in the process of delayed cord clamping in our setup. We usually get a call or a memo for the section or delivery received in NICU. We usually send an NICU, the posted NICU CRRI. They enter the labor room and OT theaters and inform the pediatric, respective pediatric PG or the faculty with basic demographic details of the mother. And they also counsel the mother as of how we're planning to do this delayed cord clamping and what all doubts she has while doing delayed cord clamping. And then we wait. When the baby cries, then we do routine care on the mother's abdomen in vaginal delivery or thigh-in sections, and we time the cord clamping. And then we establish feeding and then shift to mother's side. If the baby did not cry, then we do early cord clamping, we cut, and resuscitation is performed then and there. So then if the baby is improved, then we establish feeding on the mother's side. If the baby did not improve, then we shift to NICU. Methodology: data was collected by pediatric PGs daily, and daily data was reviewed and analyzed in every PDSA cycle. Run charts were constructed using Excel sheets. Analysis was done with control charts, and incidence of the delayed cord clamping was considered significant when 6 consecutive points rule or points more than 3 standard deviation from mean rule. So the need for phototherapy for neonatal hyperbilirubinemia was noted as a balancing outcome. Inclusion criteria was all term, more than 37 weeks, cried immediately at birth, irrespective of the mode of delivery. Exclusion: baby with congenital anomalies, mothers with abruptio placenta, antepartum hemorrhage, and babies who required immediate resuscitation was excluded. The sample size, we aimed for a subgroup of 5 by the probability before the implementation of program was 44%. So we aimed for around 15 babies, minimum subgroup size for every PDSA cycle. We kept it as 15 babies. We aim to achieve a goal of 100% DCC among eligible term units. This was PDSA cycle 1.
we planned to implement the policy, and we kept educational sessions for staff, nurses, and PGs, and we studied and we studied the practice guidelines, and we acted like we kept review meeting every 10 to 15 days, and we addressed all the technical issues they had. So after the implementation of PDSA cycle 1, from initial 44%, we were able to achieve almost 60%. But then there was a fall after the PDSA cycle 1, which was due to constant CRRI rotation. So that's when we adapted the PDSA cycle 1 and we moved to PDSA cycle 2, because we found there was some increase in the incidence. PDSA cycle 2 is to train all the CRRIs who are posted in rotation, and we made them to time the cord clamping. We had issues with timers in each labor rooms and operation theaters. So we ensured there was adequate spare batteries in all the timers, and we trained the CRRIs to time the cord clamping. After the PDSA cycle 2, we saw the incidence of DCC was reaching up to 70 to 75%, and CRRIs were made to document in the case sheet as of the delayed cord clamping done or not. So this was PDSA cycle 3. Even though there was the rise in the incidence of DCC, we were not able to reach almost 100%. So we plan to conduct simulation workshops by the obstetricians, and the incidence after this only was increasing up to 95%. And then also we didn't reach 100%. Then we decided to send all the respective pediatric assistants and postgraduates, whoever gets a call from the memo, to go inside the OT room or delivery area and to wait after the baby cried, to wait for a minute before they got the clamp. After doing this, we saw an incidence of DCC reaching 100%, and we also aim to sustain this 100%, sir. And this was the balancing factor, phototherapy. Before and after implementation of the delayed cord clamping, the incidence was remained around 14 to 16%. There was 3 high peaks because of ABU and RH incompatibility then and there. So the discussion is
complete.
Yes. So the discussion is, even though we all had knowledge about delayed cord clamping, major shift in trend was observed after the simulation workshop, sir. And then we are planning to continue the same incidents. The review of literature, the Cochrane studies have also. Yes, sir. Thank you, sir.
What was your role in this study?
So I was being a communicator, sir, between every PDSA cycle, and to train all the pediatric interns who are posted in NICU, and to communicate the labor room staff nurses to pediatric assistants who were posted, because there was constant change in postings. So I was one who's being mutual and communicating to whoever was posted, and then to train them to document in the case sheet, also to train obstetric PGs to do delayed cord clamping.
Where did you learn QI?
Quality improvement study in our hospital, sir, and then the
workshop. There was some workshop you attended?
No, sir. We read some articles regarding QI, and then we learned about QI, and then we implemented.
Any more QI studies?
Sorry, sir. We are planning to do more QI studies on skin-to-skin contacts post-delivery of the baby. We are planning to do it in the future, like in next 2 to 3 months. We are planning to implement post-delivery to start skin-to-skin contact and to do resuscitation if required on the mother's abdomen. So that is the next plan for us.
So your process flow chart
Yes, sir.
showed 2 clouds.
Yes, sir.
Okay. So one cloud was timing of the clamp.
Yes, sir.
So before that you had 40%. That is why you put a clamp, because
Yes, sir. Yes,
others
sir.
may not be doing.
Yes,
Why
sir.
clouds
Why
are
the
there?
cloud was?
Why clouds are there?
Yeah, because it was not being done before the implementation of the program, and the process of timing the cloud.
Then show it.
Yes, I can show it. That was not happening before the implementation of the program, so that is why I put that in a cloud. Yeah, and the counseling part also was not done before. After implementation of QI only, we were able to put these. So that's why.
So what is the delivery rate in your place? Because you said you will do a 1 PDSA for 15 babies. So how many babies are being born?
40 to 45 deliveries. Like 1 PDSA cycle for every 40 to 45 deliveries.
You said 5 by 0.44.
The subgroup size, sir.
Subgroup for 1 PDSA, obviously, was for 15 babies. Huh? You are taking up 45 babies in
subgroup for the specific dates, sir. September 1 to 6, 7 to 12. So that subgroup we aim for minimum of 15 babies.
15.
Sir.
So your delivery rate is how much?
Delivery rates.
Per day, how many deliveries occur?
Per day, 10 to 12, sir.
Okay. So you could do 1 PDSA cycle in
subgroup size
assessment in 1.5 days.
1.5 days, sir. Yes.
The first PDSA was the policy implementation.
Yes, sir.
PDSA 1.
Yes, sir.
So what was the policy? What in that PDSA did you show this? Because this was not shown in the other paper. What policy was shown?
Yes,
But did you make a new policy?
No, so this policy is implemented as a policy now only, sir, because previously they've been doing it, but they're not continuously doing it for all babies. They were just randomly doing it, and no people were aware of the existence of the policy. So we implemented DCC as a policy only in pediatric cycle 1, sir.
In your policy SOP, was there already an existing policy on delayed cord clamping?
No, sir, there was no existing policy on DCC, sir. This was after
So
the
you made a new policy. Okay.
Yes, sir. Yes, sir. We made a new policy in our setup, sir.
Simulation workshop actually helped a lot. No.
Yes, sir. That only after conducting simulation workshops only we could see major trend in the shift of DCC incidents, sir.
But ultimately, the thing which actually made the difference was PG resident going and doing it personally. Do you feel this is sustainable?
No, sir. Actually, now also we are planning to send all pediatric residents and pediatric assistants, whoever is getting called, to go inside the delivery area and then call for delayed cord clamping then and there. So we're planning to do that in your future.
So, Preeti, after this study,
yes, sir.
Do you want to change the SOP of your hospital?
Yes, sir.
As a part of the results of this QI
yes,
study
sir.
which you did,
yes, sir.
do you intend to change the SOP after the 4 pediatric cycles you have learned?
Yes, sir. Yes, sir.
So what would be the main thing of your SOP?
To sustain the incidence of DCC in the
As a part of this, to have successful delayed cord clamping.
and then we're planning to implement the same thing in preterm units also, sir, because we've been doing it on input.
The SOP, what would you like the SOP so that you stick it so that new resident which is coming knows what this is happening?
Okay.
What is the change behavior which you
That they
find?
have to be inside the delivery area. Yes, sir.
Cool.
Thank you so much, sir. Thank you.
Kalati Vaishnavi. शेयर करना
Stop sharing the
इधर शेयरिंग है वो सब पे जा रहा है
नहीं they are sharing the folder currently.
which it is I think they are sharing.
Good afternoon, sir. Good afternoon, everyone. I'm going to talk about the role of cranial ultrasound in evaluation of brain injuries in preterms. Ours is a Prashanti hospital, which is in a very small town in Telangana. It is mainly predominantly a women hospital with deliveries. So we have conducted this study to know the incidence of the preterm brain injuries, because initially we used to refer all these babies to a higher center. From past 1 year, we thought of treating here only, and we have studied how much is the incidence in our hospital. So preterm neonates have more likelihood of neurological abnormalities due to intracranial hemorrhage, perinatal asphyxia, and congenital abnormalities. And early recognition of these conditions is very important for the proper management. And for this, cranial ultrasound is used to diagnose such conditions right at the bedside. It helps in assessing the neurological status of the infant, as clinical examination symptoms are very non-specific in preterms. In neonates surviving with cerebral injury, it may also help to optimize the treatment of the infant during the neonatal period and thereafter also. So it has become an essential part in the newborn care. So our aims and objectives of the study is to screen the high-risk preterm neonates, which are admitted in our NSU, which is a level 2 NSU, and to evaluate the usefulness of neurosonogram in identification, grading, and diagnosis of various brain lesions, and to evaluate the possible use in determining the prognosis and outcome at the end of the study. So it was a prospective study which was studied in Warangal, Telangana for a period of 1 year. We have included 30 preterms born prior to 32 weeks and who are 1500 gram and less. So preterms with abnormal neurological findings like seizures, lethargy, apnea, and sudden onset of pallor, increase in muscle tone, bulging anterior fontanelle were included in the study. And we have excluded babies with congenital malformation, severe infection, and failed resuscitation. So informed consent was taken from parents, and assessment of factors was done who were in high risk by taking the maternal history and reviewing their antenatal records. And all perinatal details were recorded, and detailed clinical examination was done within the 24 to 48 hours. And cranial ultrasound was done as per protocol by day 1, day 3, and day 7 of life. And if any neurosonogram revealed any abnormal findings, and we used to repeat the neurosonogram to follow up any sequelae, and we had followed them till recovery and discharge from the NICU. We have used logic key ultrasound machine using the curvilinear probe, which has a low frequency of 1 to 5 megahertz. So these were the findings we have got. We have taken 58 neonates who were included in the inclusion criteria, and out of which 79% of the babies had normal ultrasound, and abnormal ultrasound was found in 21% of these babies, and more of them, around 12%, were having germinal matrix hemorrhage. Around 1 baby was having ventriculomegaly. And we have also correlated the abnormal ultrasound findings with the days of life. So most of the abnormal findings were found within 24 to 72 hours of life, which was around 66% of babies having germinal matrix hemorrhage. And within 24 hours also, germinal matrix hemorrhage was found out. However, the leukomalacia and ventriculomegaly was detected after 72 hours of life. So we have also assessed the outcome of these babies. Cured means who are neurologically normal, cured of all the symptoms. They were 88% of the babies were having the normal outcome. However, around 7% of the babies, though they were having mild neurological abnormalities, however, they were relieved of the symptoms of seizures and abnormal, however, they had mild abnormal neurological examination. And of them, around 3% of the baby went lama because of financial issues. And 1 baby who was very sick, baby had succumbed to sepsis. So we have concluded that it is a very important tool in screening of neonatal brain and diagnosing various brain lesions, and it is very safe and radiation free, no sedation risk, and cost effective also. And it is the portability makes it a best diagnostic modality to evaluate the sick newborns, and it is also best modality to assess the neurological complications in seriously ill newborns and to disclose to the parents the long-term neurological outcome. So it is best sensitive and specific for detecting the germinal matrix hemorrhage and periventricular leukomalacia. However, we had few limitations in our study. Our sample size was small because the number of deliveries conducted in our small town hospital was also less. And we should have done a neurodevelopmental follow-up who had abnormal preterm abnormal ultrasound, and it was totally dependent on radiologist opinion. And it was very difficult to detect any migration disorders and cortical dysplasias. Thank you.
Did you do any of the ultrasounds? Or?
I've learned, sir, from the radiologist, and I've attended the workshop this time also.
You are able to?
Yes, sir. I'm like after working, attending the workshop, I feel I'm better now.
The rationale for doing ultrasound on the first day, because most of your places where there are limited resources, there's no need to do on the first day unless there is some strong clinical
extreme preterm less than who are born less than 28 weeks and less than 1,000 grammar, and who are born after 28 to 32 and more than 1,000 to 1,500 grammar who are on ventilator, very sick. It is better to do within 6 hours or within 1 day of life, because for such babies
are done on the first day were those small high risk.
Sir. Yes, sir. Yes, sir.
So how does your study add to existing knowledge?
It is already there in the knowledge, sir, but we have conducted this study to know how is the incidence so that we can improve our hospital outcome of the babies, sir. Initially, we used to refer all these babies. So for past 1 year,
how strong is ultrasound alone? But that's one of your aims. So is ultrasound alone, and how much use is it in prognostication in a small baby?
It very well helps in prognosticating the baby. So if we find the grade 3 hemorrhage or grade 4 hemorrhage, is best initially to prognosticate the parents and we can know the outcome. However,
this is retrospective study, prospective study. What kind of study did you do?
For past 1 year.
Did you follow some guidelines for those? How to report that?
Sir,
how the sample size was calculated? 58.
Sir, actually, we have taken all the newborns.
Your objectives, you can just show me the objectives. They were get the efficacy, evaluate the usefulness of neurosonograph. How have you evaluated the usefulness of neurosonograph?
Sir, the thing is like initially we used to refer all the babies who were sick.
No, but what is the outcome? Where is the outcome? Where is the outcome of usefulness?
It is still yet to be studied, sir, because it's our new hospital.
Did you attend any research methodology workshop? अल्ट्रासाउंड नहीं सीखना था, रिसर्च मेथोडोलॉजी सीखना था पहले।
Sir, in our
अल्ट्रासाउंड
PD
कैसे सीखना
camps,
है?
we have attended, but because after that, like to improvise our hospital, we have
डॉक्टर रामजी कोई नहीं है, यूजफुल भी नहीं है, कॉस्ट इफेक्टिव भी नहीं है, कहीं भी नहीं है। ये आउटकम पर नॉट
we go for MRI and CT. Obviously, ours is very small term. Who has very financial?
वो ठीक है कालती
Our innovation poster. Innovation poster paper. Paper one. Presentation one room में join.
the money was spent this much, calculate.
The next project is that.
Innovation posters.
Alfie, don't do any research without learning.
Presentation one में doctor
Based all the time,
he's presenting, he's
you
listening.
said all perinatal data was collected. Why? What was the need to collect all perinatal data? Collect relevant data, which is relevant to this.
Innovation poster. Innovation poster.
What was the data regarding the gestation age, birth age? There's no correlation with it. Could you correlate?
Sir,
There was no correlation which was shown. You just collected some data, but do it in a manner where it makes some relevance and adds up to the value.
Yes, sir.
So please.
Our more ಕೊಡಬೇಕು.
Yes, sir.
Our innovation poster one our two ಹೋಗ್ಲಿ.
Yes,
Two
sir.
ಹೋಗ್ಬೇಕು.
Actually,
our two
we
ಹೋಗ್ಬೇಕು.
can pass us
Our innovation poster
I have your
सबसे पहले रिसर्च पढ़ना है भाई।
Yes, sir. Sure, sir. Sure, sir. Thank you. Thank you.
Okay. To tell your name and don't sit down.
Microphone muted, please.
Exit procedure. Fine. Please present. It's visible. I think.
We'll ask for this person, na? Better in the chat, sir. Doctor Deepthi. Deepa, Deepthi, sir. Deepthi. Yeah. Everybody has designed something, but there is no way of comparing anything.
Other all is coming.
No, the comparison was done by only this person. But again, this is people, since they themselves are deciding, they themselves are evaluating. There is a lot of bias. Won't to choose.
He was also fed up with this because he was looking after the all in the morning.
ಲೋಡ್ ಮಾಡಕ್ಕಾಗುತ್ತೆ ಶೇರ್ ಮಾಡಕ್ಕಾಗುತ್ತೆ yes ಮೊಬೈಲ್ ಅಲ್ಲಿ ಶೇರ್ ಮಾಡಿ ಲೋಡ್ ಮಾಡಬೇಕು
अरे इसका आवाज से दूर कर हमको सुनना नहीं है ना हमको सुनना है
हाँ वो इतना नहीं
हमारा स्पीकर बंद कर दिया
No, he can't. He doesn't have the power to move.
करेगा हमारा स्पीकर बंद कर
हाँ I got it.
Sir, 3 more are logging in virtually, sir.
यहाँ पे आवाज कैसे कम करते हैं? I got the idea, sir. Yeah, done.
Now you carry on.
Good afternoon, everyone. I'll be presenting an interim analysis on a study conducted on the validity of acute physiology derangements for the diagnosis of early onset neonatal sepsis. So we know neonatal sepsis is a clinical syndrome presenting with a spectrum of clinical manifestations caused by pathogenic organisms including bacteria, fungi, and viruses. It is further classified based on the time of onset into early onset and late onset, with early onset defined as onset of symptoms before 72 hours of life. The global burden of disease study in 2016-17 identified an annual incident of 1.3 million cases with 203,000 sepsis attributable deaths. The NICSD Neonatal Research Network found an overall incidence of 1.08 cases per 1,000 live births, with the highest incidence being amongst 22 to 28 weeks of gestation and amongst the very low birth weight infants. India itself contributes to 17,000 per 1 lakh live births of clinical sepsis, and the incidence of culture positive sepsis, as per one of the studies, were found to be 9.5 per 1,000 live births. So with this background, we came up with the hypothesis that monitoring acute physiology derangements in terms of sensorium, temperature, oxygenation, perfusion, and blood sugar, calculated as a clinical scoring system, would be as effective as other modalities of identification of early onset neonatal sepsis. And the aim was to evaluate the validity of these acute physiology derangements, given as an acronym of STOPS, for the diagnosis of early onset neonatal sepsis. The primary objectives were to evaluate the validity of acute physiology derangements in diagnosis of EONS, and the secondary objectives were to compare the STOP score with the hematological scoring system and identify the individual performances of the parameters of the STOP score in identification of early onset neonatal sepsis. The study was an observational analytical diagnostic study, which included neonates born to mothers with risk factors for early onset neonatal sepsis, conducted over a period of 18 months in the NICU and the postnatal ward of a tertiary care hospital. The sample size was calculated to be 96, keeping an incidence of EONS at 8 per 1,000 live births with a confidence interval of 95% and the absolute error of margin at 10% for either side of sensitivity. The inclusion and exclusion criteria were to include patients born to mothers with PROM of more than, that is, pre-labor rupture of membranes of more than 18 hours, preterm pre-labor rupture of membranes, foul-smelling liquor, meconium-stained amniotic fluid, clinical chorioamnionitis, and history of maternal fever or dysuria or diarrhea within the preceding 7 days of delivery. Neonates with congenital malformations, inborn errors of metabolism, and birth asphyxia as defined were excluded from the study. For diagnosis of early onset neonatal sepsis, the gold standard remained culture for culture positive sepsis, and for culture negative sepsis, we had taken hematological scoring system, which is the Rodwell score, along with or without procalcitonin or QCRP, quantitative CRP, whichever was available to us, as well as the histopathological examination of the placenta, which we had also taken into account for that.
मैंने ज्वाइन कर दिया तेरा Zoom.
So for the evaluation, hematological scoring was done at 4 to 6 hours from birth on day 1 and day 2. The procalcitonin and CRP were done along with the hematological scoring system. The blood cultures were taken at birth and prior to any antibiotic change, and the STOP scores were taken at 6 hours intervals for at least four evaluations. The hematological scoring system involves 7 parameters which are assessed, and the interpretation is less than 2 was sepsis very unlikely. 3 or 4 was sepsis was suspected, and more than 5 had sepsis. This was the STOP score which we had prepared for evaluation of studies. Each parameter got a scoring of between 0, 1, and 2, and 0 being scores of normal for all the parameters, and 1 and 2 respectively the amount of discrepancy that they had. And the interpretation was those with an absolute score of 0 or 1 were normal. 2 to 3 we had repeated the STOP score to find whether there was any change and whether it was persisting to be abnormal, and 4 to 10 was definitely abnormal. We had compared the STOP score against the standard which we had defined, and tried to find out the sensitivity, specificity, positive and negative predictive values of the STOP score. For the secondary outcomes, we had compared STOP score to the hematological scoring system itself and the sensitivity and specificity of the individual parameters of the STOP score for the diagnosis of early onset neonatal sepsis. This was the flow of the study. Once the neonatals were enrolled, they were divided into symptomatic and asymptomatic, and further on evaluation, they were categorized into no sepsis, culture positive sepsis, and culture negative but low HSS positive plus minus procalcitonin or QCRP positive sepsis. And finally, we were planning to analyze, but this was just an interim analysis of the same. So for the interim analysis, we had enrolled 72 neonates with the mean weight of 2.26 kgs and a mean gestational age of 33.3 weeks. Out of which there were 65.2% neonates which are preterm and 34.8% patients with no term. Less than 32 weeks comprised of almost 29% of the patients. And 8.5% The maternal demographic data showed a mean maternal age of 27.7 years. PROM was present in 21, which was a mean duration of 30.9 hours, and preterm pre-labor rupture of membranes was present in 47 of these units with a mean duration of 94.17 hours. In units born less than 34 weeks, steroid course was completed in 21. It was at least a single dose was given in almost 12 of them. Based on the standard, gold standard that were defined, we had divided them into no sepsis, which was in 63.8% of the neonates. Culture positive sepsis was present in 8.3% neonates, and the culture negative sepsis was present in 27.7% of the units. There were a total of 6 patients who had culture positivity, out of which 4 had Klebsiella, 1 has had Acinetobacter baumannii, and the last one had Enterococcus faecalis. So for the primary and the secondary outcomes, it found that the stop score versus the standard that we had defined had a sensitivity of almost 88.46% and a negative predictive value of 90.6%, which I'll be showing in the graphical representations.
The time is up, but you can wind up.
Just 2 more slides left. This is the sensitivity and specificity of individual parameters, which we are seeing that individual sensitivity and sensitivities were not high for either of the parameters except for the oxygenation. And lastly, to discuss that stop score was a cost-effective method of evaluation, as there was hardly any cost which was required for evaluating as per stop score. It was easy to apply. We had trained the nursing staff for identification of the stops parameters, and in comparative sensitivity of other biomarkers commonly used, there's a meta-analysis which showed that procalcitonin had a diagnostic sensitivity of
I think I missed it in the presentation. How did you decide those who are at risk of early onset sepsis? What are the criteria?
So the criteria was preterm rupture of membrane, pre-labor rupture of membranes of more than 18 hours, sir. Preterm pre-labor rupture of membranes.
The Rodwell score, no.
No, sir. The high risk criteria were these, sir. Present of foul smelling liquor, clinical chorioamnionitis, and history of maternal fever, which we have
on these babies, we were doing a stop.
We were doing stops as well as the hematological scoring system and the blood cultures.
The validity. In fact, if you want to use it as a public, as a screening tool, what would you concentrate more on? Screening or specificity? Sorry, sensitivity or specificity?
So specificity would be, if it's just a screening tool, would require high specificity.
So the cutoffs were not taken. Cutoffs of when you were trying to take this score, who has you said you have made this score of stop score?
Sir, actually this was the idea of the scoring was taken from another DM study which was conducted in KIMS.
The acronym stop is already in the FBNC module.
Yes,
but I don't see a score over there.
No, sir.
Have you devised this score yourself in your place?
No, sir. The idea of it was taken from the study which it has been published in 2020 also, sir.
So there was some study which was published. So from that, you have
yes, sir. We have taken the idea from that.
How does it differ from the other CRIB scores which are already available? The many scores that were already.
Yes, sir.
But that was not part of your study.
Not part of
it. You did not study that. Did you read through it? That was the.
So not all of the scores, but I've come across while doing the
review of
new
score which you have.
Yes, sir. Because otherwise, there's just one study which has started stop score particularly and in diagnosis of PONS, but not routinely.
On the basis of this study, what is your recommendation?
Sir, on the basis of the study, the gold standard remains the culture, sir. But stop score can be used as a scoring system because it has got similar sensitivity and positive predictive value as compared to the other biomarkers. So in case we do not have a biomarker readily present, then we can use it as a screening tool to start the antibiotics for the patients.
Most of the patients were at risk.
Yes. Yes, sir.
So when physician will withhold antibiotics, look at the stop score and then decide antibiotics because it could be too late.
How long does it take to take one stop score?
So it takes 10 minutes, hardly 10 minutes.
But you are doing it every 4 hours.
So we had done it every 6 hours, sir. But these values were taken every 6 hours. But in our setup, we are doing these parameters every hour.
Temperature लेने में saturation लेने
hardly.
So child with these risk factors, sir, would you not cover them with antibiotics?
We do, sir. We do, sir. But
so the child is already on antibiotics.
Yes, sir.
Then you are doing stop score.
But sir, we started with the culture, and within the first 6 hours, we have taken the 4 to 6 hours, we have taken the first biochemical parameters as well. The stop score rate started from then itself, sir. So
your antibiotic is already on. So you anyway till the culture comes, you
yes,
will not be able to stop the antibiotic, correct?
Yes, sir.
So then how does the stop score help you? Whether it's the stop score, whether it's abnormal or normal, so you are going to wait for the gold standard to tell you that I'll
yes, sir. But the issue with the gold standard is that the culture positivity is very low, sir.
In which setting this score will be helpful?
Yes, sir. In a setting where the
gold standards are available everywhere.
So not everywhere, sir. And the smaller units where the biochemical parameters are the lab facilities are not good enough to.
So it's a clinical score. It can be used in settings where the सारे tests नहीं हो सकते.
Yes, sir.
This is.
You combine two criteria as gold standard. In culture negative, you use what is not gold standard as the gold standard. You can't compare them. You cannot combine a blood culture with a CRP and say this is gold standard.
So we had kept, if the culture was positive, the culture.
No, but gold standard is gold standard. You
Yes,
can't
sir.
have two gold standards.
There were three.
When you said so your thing is I look at culture positivity versus everybody else.
Sir.
So you can't say you calculate your sensitivity and stress. I've read it has combined both the those who were culture negative but positive for your
Yes, sir.
CRP.
It takes for
versus
combined.
blood
Yes, sir.
culture.
It takes for combined. Sir.
But CRP itself is a very poor marker of sepsis or anything else. It's not a marker of sepsis at all. See, if you had said I used PCR and then looked at something and said I did not get a culture, I used PCR for diagnosis because you are identifying an organism. But the combination of that is not a correct mistake.
Yes, but then we validate it just based on the program cannot be.
No. So your combination of both sides itself is a problem.
So,
and second, as Dr. Vaidya said, ideally the study should have been done with no treatment being done because you first of all want to know how many of them actually end up. Maybe many of them don't. Nothing ever happens to them.
Yes.
You know what's the likelihood of a child who's blood culture positive and asymptomatic and has no symptoms? So there's a big issue about this. So ideally, as he said, for the study purpose, you should withhold antibiotics and observe them for let's say 48 hours or so. And if something happens, you start antibiotics. Otherwise, you're okay with this and nothing will happen. Because you already vitiated part of the story by the addition of antibiotics. But gold standard is a combination of a gold standard versus something which anyways measured against a gold standard cannot be done. You can't have two things molded as one.
Good, Tavesh, but good, very good study done, very properly done study. Only thing there were some issues in the conception of the gold standard that is beyond your control at times.
Nice.
Colonel Shaw.
No, sir. Yeah. 30.
Good afternoon, sir. The topic is gestational age-specific nomogram of transcutaneous bilirubin in first 120 hours of life for term and late preterm Indian neonates. It's a multicentric study. So we mostly follow AP nomogram and at times NICE nomograms also, but they are foreign in origin and they are used for starting phototherapy or exchange transfusion in case of significant hyperbilirubinemia. Indian neonates are ethnically different with a higher incidence of IUGR and also they are predominantly breastfed. Indian studies who have attempted making nomograms, the last three in last decade are written there. I'll discuss them in discussion also. So we plan to do a multicentric study with adequate sample size because we felt the sample size was low in the previous studies and thus collecting a true multi-ethnic pan-Indian data which was available in army setup and we did it in 4 army hospitals. So the objective was to create a nomogram based on transcutaneous bilirubin values in first week of life for term and late preterm neonates. Secondary objective was to ascertain the factors having significant association with significant hyperbilirubinemia requiring phototherapy. Now for recombinant phototherapy, we followed AP charts. So methodology was like this. It's a multicentric prospective longitudinal study and it was done in 4 centers, one in FMC Command Hospital Pune, 2 in Northern India, Army Hospital R&R and Base Hospital, and 1 in Eastern India, Vizag. It was done between February 2019 to March 2020, and informed consent was taken from one of the parents and also approved by Institutional Ethics Committee, and we also got it registered in CTRA. So the what we took inborn neonates more than 34 weeks of gestation, and the exclusion criteria were infants with major malformations and those who were admitted on NICU because we were not following the NICU babies, and any neonate with positive direct womb test, whether ABO or RS, and those on phototherapy before enrollment for any reason. So we used Dagger JM105, and we used to calibrate it every day, and forehead was chosen for measuring TCB. All neonates underwent 12-hourly TCB measurement. So the TCB measurement was done in our specific time, let's say 8 to 10 in the morning, and again in the evening around 8 to 10. So depending on the hours of life the baby had, we used to record the data. So post-discharge, all neonates are called for review in next 48 hours. Generally, we discharge at around 48 to 72 hours life. And we used to get a fair amount of babies by day 5, but after that, there was very less number of cases.
Excuse me. Am I audible? Something gone wrong.
Slides are not visible. And the presentation stopped.
There are people who are
All cases which are presenting with colonic atresia, they should be looked for Hirschsprung disease as well. So we should take biopsies from
Raj.
Everything has to be now registered in CTR, right? कराना पड़ता है। नहीं आज नहीं बाकी सब कुछ भी करा देना। All studies have to be registered in CTR.
ಇದಾ
ಯಾವುದು ಡಿಪ್ಯೂಟಿ
ಶೇರ್ ಮಾಡಿದ್ರು
क्या बिल गेट्स सब जोड़ दोगे?
Neocon at the Bill Gates.
अरे वाह बिल एंड मेलिंडा गेट्स फाउंडेशन से आ रहा है कुछ बिल गेट्स इज वाचिंग
सेंटर ಹಾಕಿದ್ರೆ ಯಾವುದು ರಿಪೋರ್ಟ್
मस्त हियरिंग नहीं होता है No offense, Desa.
PPT open ಮಾಡಿ first. Open.
Hello, sir. Good afternoon, sir. Am I audible? Hello.
ಮಾಡಿದ್ದು last time.
Hello. Hello. Hello.
Can you start? Good afternoon, everyone. My topic is temperature monitoring in children and agreement study. Background: accurate temperature recording remains an essential component of the care. Glass mercury thermometer, now rarely used, is the gold standard. It has been replaced by many different types of modern digital and infrared thermometers like non-contact infrared thermometer (NCIT), which is rapid, non-invasive, less distress to children. The risk of the cross infection is negligible. Neither disinfection nor disposable probe covers are needed. Forehead NCIT is less accurate than the digital auxiliary. Use of NCITs at forehead is widely studied, but other potential sites like axilla and abdomen are yet to be explored by temperature monitoring with NCITs. Hypothesis: as axilla and body parts are covered with cloth, we hypothesize that the temperature using NCIT at various sites will agree more with mercury axillary temperature than at forehead. The primary objective were to compare agreement of temperature recordings of the axillary temperature by mercury thermometer with axillary temperature by digital thermometer, NCIT at forehead, NCIT at axilla, NCIT at mid-abdomen, and NCIT at right hypochondrium area. And secondary objective was to compare incidence of hypothermia and hyperthermia between the groups. Inclusion criteria was under 5-year children from 0 hour of life to the 5 years of age. And exclusion criteria was neonates under the radiant warmer and neonates or children cared with the heater besides the bed. An agreement study was conducted in step-down neonatal ward, postnatal ward, and pediatric ward of a teaching institute. Institutional ethics committee approved the study. Temperature recordings were recorded using these equipments like glass mercury thermometer at the right axilla, digital thermometer at the right axilla, NCIT at forehead, NCIT at mid-abdomen, above the umbilicus, NCIT at right hypochondrium, and NCIT at right axilla. At the time of routine temperature monitoring, the temperatures by above mentioned equipments were measured. No intervention were done as a part of this study. If abnormal temperature was found, it was conveyed to the treating doctor. The agreement between the various methods were presented as a mean difference of 95% confidence limit of the difference using the bland Altman analysis. Mean difference within the 0.2 degrees Celsius, confidence limit within plus or minus 0.5 degrees Celsius, and less than 5% of outsider of 95% confidence limit were considered to be the good agreement. Result: we enrolled total 102 participants under the 5 year of age, divided into two groups, Group A and Group B. Group B was neonates, and Group A was neonates, and Group B was more than 1 month to 5 year of age. Total 68 participants in Group A and 34 participants in Group B. Total 309 samples were collected, and 23 of female under and 45 male from Group A, and 13 female and 21 male from Group B. And now, as per the bland Altman analysis plot, first of all, mercury auxiliary versus the digital auxiliary, we compared in both the group neonates and 1 month to 5 year of age. You can see over here there is a mean difference in minus 0.046, which is very narrow, and the confidence limit, 95% confidence limit, is minus 0.2 to 0.1 in neonate age, and here mean difference is minus 0.033, and 95% confidence limit is minus 0.2 to 0.14. It indicates that there is a good agreement between the mercury auxiliary versus the digital auxiliary. Or you can see mercury auxiliary versus NCIT at forehead. In this, mean difference is 0.008, but the 95% confidence limit is minus 0.6 to 0.6. As per prior, we have decided it's supposed to be within the plus or minus 0.5 degrees Celsius. So this is acceptable, not the good agreement. 0.2 for mean difference, and plus or minus 0.5 for confidence limit. And here in older age people, it is minus 0.1 a mean difference, and 95 confidence limit was minus 0.8 to 0.5. Now in mercury auxiliary versus the NCIT auxiliary, that is mean difference is used minus 0.4 and confidence limit is minus 1 to 0.1. And in older people also there is a mean difference is minus 0.4 and 95% confidence limit is minus 1, which is not acceptable. It's a poor agreement. As also in mercury auxiliary versus the NCIT at mid-eminent, there is also a poor agreement. You can see the mean difference is minus 0.4 and confidence limit is minus 1. In mercury auxiliary versus the NCIT at dry hypochondrium, it is also suggests that there is a poor agreement within this group. So the summary of this all the alignment plot, I have given this one table. You can see that digital axilla, forehead, infrared axilla, mid abdomen, and right hypochondrium. There is a mean difference of minus 0.046 and 95% confidence limit is minus 0.26, which is good agreement. And forehead infrared is acceptable. Rest of the things are poor agreement. Now the secondary objective was to compare the incidence of hypothermia and hyperthermia among this group. So in group A, neonates, there is a more reading, hyperthermic reading. You can see in infrared axilla, there is a 121, which is 60% among the all 309 sample. And for in mid abdomen, there is a 103, and right hypochondrium, there is 145. Means NCIT at axilla, at mid abdomen, and at right hypochondrium demonstrate the more hypothermic result. In these older people, also same result we found. NCIT at axilla, mid abdomen, and right hypochondrium demonstrate more hypothermic result. So the conclusion of these whole studies, the agreement of digital axillary temperature was good. The agreement of NCIT forehead temperature was acceptable. The agreement was poor for NCIT at other side, like hypochondrium, axilla, and abdomen. Important to be considered is magnitude of the agreement may depend on brand, calibration, standardization, and temperature recorder skill and technology, etc. Thank you.
I like the concept of the study. It's very relevant in today's age. But I think other than the newborn, in the older people, they are more interested in hyperthermia than hypo, right? Most of the older children say about 5 years old, they want to pick up fever rather than hypothermia.
Yes.
And in newborn, you're more interested in picking up the hypothermia. Is that right? Is it the right thing to infer?
Yes. For newborn purpose, we mostly like to consider.
What is the implication of this study? What would you recommend?
We recommend as the goal for body temperature, gold standard is mercury, but nowadays we are using digital thermometer. But while doing this study, the troublesome which I have faced, for taking 3 minute or 5 minute auxiliary temperature, the baby gets irritable. So especially in COVID scenario and other routine days nowadays, as NCIT, we have this latent technology over here. So the forehead temperature was widely studied, but the axilla, baby usually covered by the cloth and all layer. So we hypothesize that the axilla, mid abdomen, and right hypochondrium supposed to be accurate as compared to the axillary gold standard. So NCIT temperature, but in this study, NCIT temperature was more as compared to the.
So you mean that there is no need to check it in the axilla or anywhere else? You can check the forehead one,
Yeah, that's what.
and that got a reasonable correlation with the
Reasonable, but not acceptable agreement, but acceptable.
But the axillary one correlated, correct?
It was digital.
Digital and mercury had
Mercury and digital actually was correlated, which is also which is the now
which we know.
Which we know.
They use actually interest in the new technology. The new technology actually doesn't seem to work as well.
Yes.
But at the forehead it worked.
It worked, but acceptable, not because confidence limit was minus 0.6 to 0.6.
In all this, I really feel I wanted to do the same study myself.
Okay.
Because so this is the study even I wanted to do, and in my postnatal ward I really want to give one infrared thermometer after the COVID has come,
Yes.
so that you please go and check the thermometers, because the sisters in a ward,
Yes,
public,
yes,
the hundreds of babies, they are not able to, whatever they do, they don't
That's
pick
what
up
we thought.
hypothermia. Okay, so having any such modality which can do would happen. So I was really wanting to look at the results also. Okay.
Thank you.
Good. So in your which hospital you are working where mercury thermometers are allowed? Okay, it was ethically passed by your ethical society, ethical committee to use a mercury. It is banned. It is not banned in
But
your state.
I have taken all the samples, It's very careful and gentle.
No, but your ethical committee can do this. I think if your ethical committee passed it, for study it was
study because
Normally we use
digital. In our setup, we are using digital one. But we are interested in
sample size. How sample 102 came up.
So sample size, suppose as blind elements suggest that the 300 sample is adequate to take these agreements.
Calculated by some studies.
Yes,
Which was the study? You did not show what was the difference.
Difference.
He used the expected
Blind element is self-suggests.
to decide if you want this result, what would be the sample size, which is fine.
Good. I really.
Actually, the problem with all the other newer technologies talk about are not good for hypothermic detection. Even as a design. They were designed to detect, as you said, for fever. Our problem is that new ones don't pick up hypothermia, which is our concern. Fever, they're all very good because they're all designed to detect fever. You know, it's like a glucometer was designed to detect hyperglycemia, not hypoglycemia. So, you know, we must understand what it is. So therefore, you only revalidated what.
As a forward value, you can see confidence limit was minus 0.6. If baby in hypothermic state, then we cannot evaluate it with the help of this forward and
We have a reasonable
Talking.
worry about it. Actually, it's not such a big problem for us. If you want to have a thermometer, he's nicely clapped.
We're trying to connect it.
He will sit quietly with that thermometer.
But it takes longer time.
We have been asking where can we
Sometimes
where
we get
can
Takes
we
longer
test
time in
it?
a ward.
Yes.
So it's just not possible for staff nurses to take.
Nobody wants to answer it.
वो तो 1 मिनट में
एक मिनट तो नहीं आता फिर 1 मिनट से ज्यादा लगता है 1 मिनट में ज्यादा लगता है
Actually, the important thing to remember is even though the digital beeps, if you continue to record, the temperature continues to fall. So actually, the problem with the digital is that 1 minute is not the desired time for exposure.
1 minute.
So we have taken for 5 minutes. Irrespective of beep.
It plateaus around 3 minutes.
You take you to get despite the beep.
Despite the beep, we have taken for 5 minutes.
You can continue. We keep on recording.
Yes.
Correct.
Good.
Thank you, sir.
Panel.
Yes.
Thank you. I wanted to do this.
based on our earlier study profession IT.
Excuse me. Admin? Anybody?
Hello.
Hello.
Yes, you're audible, but admins are not audible. There's no video.
Somebody's asking.
Upload folder. You have shared the folder. They're not seeing the folder.
Video नहीं देख रहा है. Video off कर रखा है सर.
You have to open the PPT plus and then.
Video off कर रखा है.
Video on करो.
Video on करो. Video के नीचे है.
दिख रहा है video on करो.
On what is it? I asked them whether they're seeing the PPT. They are not seeing the PPT.
But कुछ भी देखेंगे तो यही है. Video ही on नहीं होगा तो क्या देखेंगे?
Any video is a person, na?
Yeah, video.
They have to see the PPT.
Video is
He's sharing the folder. He's sharing the folder. He's not sharing the PPT.
Yeah.
So they are seeing only the PPT.
Hello, sir.
Can you see the PPT? Ask them.
No, PPT is not seen.
That's what I meant telling.
इसको
Folder is
सुनो,
sharing the
इसको
folder,
बंद
not
करो।
sharing the.
उसको बंद.
Like कब
Stop
से
sharing.
बोल रहा हूँ? Stop sharing.
नहीं अब announce है.
Now share the PPT. PPT से तो वो नहीं हाँ PPT share करो. अभी वो full screen करो. Share करो. Share करो. अभी full screen करो.
Adam, can you see now?
अभी दिख रहा है?
Can you see the full screen?
Can you see?
Yes, we can see the PPT.
Okay.
No, the full screen. Full screen.
Full screen view.
Yeah, they can see.
Good afternoon, everyone. My topic for presentation is randomized control trial to compare the effect of sucrose given to infant to reduce pain during immunization against those who has not given sucrose. Background: the pain associated with injections is a source of distress for children, their parents, and if not addressed, this pain can lead to pre-procedural anxiety in future, needle fears, and non-adherence to vaccine schedules. About 10% of the population avoid vaccination and other needle procedure because of the needle fears. Orally administered sucrose are safe and effective in brain reduction in infants during single tissue damaging procedure. The sweet taste of sucrose helps to advance analgesic effect through activating endogenous opioid, which reduce nociceptive information at the level of dorsal horn. Objective: to compare the effect of sucrose given before 1 minute to infant to reduce pain during immunization against those who are not given sucrose. Method: study design, it was a randomized control trial. Study period was from January 2021 to October 2021. Study setting was immunization clinic at Teaching Institute in Anand, Gujarat. The institutional ethics committee approved the trial protocol. Written informed consent was taken for the enrollment. Inclusion criteria: infants who were vaccinated during birth and during 16 and 14 weeks. Exclusion criteria were preterm infants, clinically evident abnormal neurological signs, clinically ill neonates who received analgesic sedative in last 24 hours were excluded from the study, and breastfeeding or other distraction strategies during the procedure were not included. We randomized the babies in two groups and gave them sucrose as per randomization. Commercially available sucrose stay happy solution was given to the babies. Video recording of the infants' facial expressions were done during the procedure. Modified neonatal facial coding score was done after the break. Sample size: we assumed the moderate effect size of 0.6 as clinically important. So sample size was increased, allowing 5% type 1 error. Randomization was performed with the use of WinP software. Box plot was used to present visual comparison between the two groups. In group A, that is intervention group, sucrose was given 1 minute before the immunization. In group B, sucrose was not given before immunization. Statistical analysis: descriptive statistic mean standard deviation was used to depict the profile of the study participants. Independent sample t-test was used to compare the groups. The analysis was performed in strata 14.2. Result: baseline characteristics. Finally, we included 65 infants, that is 50 out of the 65, 58 were given birth vaccine and 7 were given 16 and 14 weeks vaccination, were included in this study. The mean weight at the day of study was 2.7 kg and gestational age was 38.2 weeks. Comparison of modified neonatal facial coding score of both groups between the two groups. Here the group A is shown, which is the intervention group, and group B is the control group. Analysis shows statistically significant difference in total modified neonatal facial coding score across the groups, that is P less than 0.001. Total modified neonatal facial coding score was significantly lower in sucrose group, that is mean was 4.91 versus the score was 7.06 in the control group. Comparison of onset of cry between the two groups. Analysis showed statistically significant difference in onset across the groups. Onset was delayed in sucrose group, that is mean second was 6.28 seconds versus the onset of cry was nearly 2 seconds in the control group, in which sucrose was not given. Comparison of duration of cry between the two groups. The analysis showed statistically significant difference in duration across the groups. Duration was shorter in sucrose group, that is the mean second was 11.9 seconds versus 18.7 seconds in control group. Discussion: the current trial suggests that administration of sucrose 1 minute before immunization is better pain control as compared to those who were not given. This study is comparable with one study which questioned the need for 2-minute interval before administering painful stimulus to the infants. That suggests that there is no need to wait 2 minutes after sucrose administration before a painful procedure. The calming effect of sucrose is thought to influence endogenous opioid mediation activated through taste receptor at the tip of the tongue and non-opioid system. Sucrose administration initiates sucking, which provides a feeling of calmness and reduce the intensity of the pain. So there is no need to wait for 2 minutes after sucrose administration. Limitation: it is a single center trial. It is an interim analysis. We did not control any prior illness or cumulative pain exposure in the infants. Conclusion: it was concluded that administration of 24% of 1 ml of oral sucrose solution was effective in reducing infantile sensation of pain in infant, as evidenced by the facial expression and presence of crying. References. Thank you.
Can you just show the objectives also? Before 1 minute, reduce pain during immunization. So when was the pain noted? here? Because we are given before 1 minute.
So we
1
give the
minute.
sucrose first. Then we waited for 1 minute before pricking for the immunization. And then after at the time of prick, we video recorded the
You
facial
said
expression.
2 minutes से ज़्यादा अच्छा होगा इससे.
2 minutes नहीं 2 minutes पे सर एक study हो चुकी है सर. There have been a
But
study.
this time you are not comparing 2 minutes versus 1 minute versus.
No, sir, there
Some
was a
giving at 2
study-
minutes, some giving at 1 minute.
Yes, yes, sir.
But your conclusion was that you were saying 1 minute is, you don't have to wait for 2 minutes.
2 minutes.
You can certainly give it 1 minute. 1
Yes,
minute
sir.
was good, but 2 minutes से ज़्यादा अच्छा करे, 2 minute हो सकता है ज़्यादा अच्छा, उसमें बिल्कुल ही नहीं आता हो, उसमें और भी कम होता होगा, cry और भी बिल्कुल नहीं होती होगी.
In short, there is no comparison 1 minute and 2 minutes in your study.
So, but the conclusion you draw was that 2 minutes से better कर सकते हैं 1 minute में.
Yes.
ठीक है, but that was not tested. You did not compare waiting for 2 minutes and 1 minute.
No.
Was it the assessment blinded?
Yes, it was single blinded study. Actually, we video recorded the videos, and the babies in which we gave sucrose, the part was clipped. So who was scoring, he was not aware about whether this baby is given sucrose or not.
The baby cried.
Yes.
Then were there any other method used to soothe the baby? Some mothers pick up, some mothers rock, some baby may suckle, mother may suckle. So once the baby cried after immunization, different mothers or caregivers will respond differently.
Yes.
So if the baby started crying, you just would left alone to measure the duration of cry, or was anything done?
No, sir.
To pacify, or was nothing done?
No,
for any
no
reason to
other
pacify?
distraction methods were not
Because
used.
sometimes you pick up and down, the baby stops. Sometimes the baby keeps on crying for 10 minutes. So you did not do anything.
No,
to
no,
stop
no other
the cry.
distraction. Yes.
You just waited.
We just waited and took the video, sir.
That's unethical. The mother allowed for that. That is unethical. Unethical.
You cannot stop
You
somebody
can't
from.
say, see, remember, your distractor was to ensure that you, as a pain relief, prior to the intervention. So that means I'm not giving breast milk, I'm not doing something else, I'm only giving sucrose. But once you are measuring something like cry and the baby doesn't settle, not to do something, it's unethical. You can't say that I left the baby.
You cannot say because you never took this. तुमने बोला तुम्हें यही कहना है कि हमने मना नहीं किया था, किसी ने करा ही नहीं था. That is what you can say.
How do you measure the time, by the way?
By the video, sir.
Then how do you measure time?
Sir, there were some sisters were
No,
also.
how did you measure it?
Sir, we video recorded the.
समझ गया.
Yes. Sir, तो जब भी सुक्रोज देना बंद किया, उसके बाद 1 मिनट तक वेट किया, मतलब जो recording दिया.
You said the baby, the two things आपने कहा. Baby started crying up so much and continued to cry so long.
Okay, sir. Stop. Why? Stop watch.
अच्छा.
You should have mentioned that.
Okay.
Measurement is time.
Preterm, you said you excluded preterm infants.
Yes.
But you are doing at 6, 10, and 14 weeks.
Yes, sir.
So you meant to say all those preterm infants who were coming at their postnatal age for vaccination. But there can be some preterm infants who must be coming at some other
Preterm
age.
excluded.
So sorry, but
Preterm exclusion.
the preterm कराया.
Exclude क्यों किया उनको?
So जो
He said term babies. He said all
No, but
preterm excluded.
preterms also do perceive a lot of pain.
Yes.
but you exclude कर दो for sake.
That's okay. Then you get a homogeneous population.
The population is similar, then it won't get confused. And preterm, then it becomes how much preterm. So those things.
Fenil,
Yes, sir.
you took mean and standard deviation. Why did you not take median and interquartile range?
Sir, it was shown in the box plot, sir.
No, for somebody else, you took mean and standard deviation for your study data. But since you said in the initial methodology only, you will take mean and standard deviation. Can you just preempt that you will always take mean and standard deviation, or you may have to take median and interquartile range as well?
If you look at the data that's published from the studies on age scores, do they follow a normal distribution or not? That's the
अच्छा
only
सर ने
question.
आंसर बता दिया.
Mean equal to, if it is a normal study curve, then mean equal to.
नहीं, इसमें था ऐसा क्या था क्या? एक
हाँ,
question.
Yes.
Your data was not parametric or non-parametric?
No, parametrics.
तो ये कुछ बाकी तो खुला था.
We presented in the department, same questions are asked. So you asked the answers ready.
Why do you say it's interim analysis के study अभी चल रहा है?
Yes, sir. It's going on, sir.
But यदि आपने effect show कर दिया है किसी randomized control study में, I would have stopped the study, saying that you've shown a benefit. You should not continue to do.
पर तुम्हारा यही outcome था, यही outcome था ना?
Sucrose then.
यही outcome था.
Interim analysis में इतना effect show हो गया है, then you don't need more samples. RCTs are usually we completely stop RCTs. The moment either they show benefit or they show harm.
So you would suggest stopping the study?
Absolutely. I know. Because the answer is very simple. You have shown a very, whatever is assumption, it has been proved, even with this size. So how much more benefit are you going to get by adding samples? See, the purpose would have been if you are borderline. Let's say I'm getting a p-value which is 0.06, not yet. So मेरे को लगता है कि if I continue to come, but इसमें तो जो भी है, it is so obviously evident. So ethically, you should actually stop this. Because the sample set is not meant before.
No, that's a bonus they got because
that is because
He's going to be very happy, sir.
No, reason I'm saying
he proved that.
If you go back, just go back to your result of the mean difference. You will get the answer for this. What is the mean difference?
अच्छा खाता है तो mean difference.
देखो.
What difference is it?
नहीं, look below. 4.1 and 7.6. What is the assumption? How much was the effect size?
Sir,
0.2.
0.6.
Look at the difference, it's 2. So you have had a much larger
effect size.
You assume the much smaller. That is why the effect size is evident in smaller samples. So you don't need to continue.
Done. Your thesis stops now.
We'll get some other thing to do now.
Yeah, very bad of you. You did a good job. You want to be making do anything.
Thank you, sir.
Thank you. Arpita.
और कितने मेमोरीज रह गए as per your assumption? और कितने करने चाहिए?
Sir, can you hear us?
Arpita, please, just wait. They will show you. They will just stop sharing. Arpita, wait. They will just stop sharing and then you can share yours.
We'll send to Indian pediatrics, sir.
Ideally, you should send it. You should have a DSMB to say stop it because you
हाँ data safety वाला DSMB से करेंगे तो आप
department committee should look at it and say we stop it because benefit has been shown. Okay. Because that's very important. Otherwise, also we need to stop it.
Share the screen.
Can I share my screen, sir?
Share your screen.
Are my slides visible?
Yeah, you can start now.
Okay, good afternoon, esteemed delegates and faculty members. I'm Dr. Arpita Kulshrestha, from junior resident from Ophthalmology, AIMS, New Delhi. In our study, we compared the outcomes of primary intravitreal ranibizumab versus laser photocoagulation for the treatment of zone 2 type 1 retinopathy of prematurity. So laser photocoagulation has been the standard of care for type 1 ROP for a long time. However, it causes permanent destruction of the retina and causes visual field constriction. Intravitreal anti-VEGF drugs, on the other hand, allow for peripheral retinal vascular regrowth and preserve the visual fields. So in the past decade, since the BEAT ROP trial, anti-VEGF drugs have slowly emerged as the first-line treatment for zone 1 ROP. In fact, ranibizumab received its approval as the first pharmacological treatment for ROP in the European Union in 2019. Another landmark study, the Rainbow trial, showed that the efficacy of ranibizumab was similar to laser in zone 1 and zone 2. So there is limited literature which comparing the outcomes of intravitreal ranibizumab and laser treatment in zone 2 ROP. So with the challenges associated in laser treatment and the fact that there is an increasing evidence on the efficacy of anti-VEGF drugs led us to explore this further. So we questioned that in preterm infants with bilateral zone 2 type 1 ROP, is ranibizumab 0.25 milligram monotherapy superior to standard laser therapy in causing complete disease regression? So our primary objective was to compare the disease regression, that is regression of bridge and plus disease with in the two treatment modalities in zone 2 type 1 ROP. And our secondary objective was to look for occurrence of reactivation, need for additional treatment, occurrence of vascular regrowth, any procedure-related morbidity, and changes in refractive error. Ours was an open label randomized control trial conducted at Dr. RP Center, AIMS. We included preterm infants with gestational age less than 34 weeks and birth weight less than 2,000 grams who had bilateral zone 2 stage 2 to 3 ROP with plus. Preterm infants who had zone 1 ROP, type 2 ROP, aggressive retinopathy of prematurity, stage 4 or 5 ROP, or who had a previous history of treatment with laser injection or surgery were excluded. So infants who were in group 1 received intravitreal ranibizumab 0.25 milligram under sucrose analgesia and topical anesthesia under aseptic precautions. And group 2 infants received standard laser treatment under low dose fentanyl infusion in the high dependency unit. Serial follow-up was done till 24 weeks and fundus examination was done at every visit. Cycloplegic refraction was performed at 60 weeks of postmenstrual age. This is how the RED-CAM imaging was obtained for the patients, and this is the image of the PhDO at our center where laser photocoagulation was done for the outborn babies. So to calculate our sample size, we assumed a success rate of 88% with standard laser treatment and 95% with ranibizumab, and at least 148 eyes in each group were expected to provide 80% power to show superiority. However, due to the COVID-19 situation, only 60 eyes of 30 preterm infants were decided to include in the study. So 528 infants were assessed for eligibility, and 36 infants were enrolled in the study, which were allocated to either intravitreal ranibizumab or standard laser therapy. Eventually 15 infants in both the groups were analyzed. So the baseline characteristics in the two groups were comparable. So we saw that disease regression in the ranibizumab group was seen in 28 out of 30 eyes, and in the laser group was seen in 24 out of 30 eyes, a difference which was not found to be statistically significant. The time to regression, on the other hand, was much shorter for ranibizumab as compared to laser. We saw that by 2 weeks, 28 out of 30 eyes had shown regression. However, that is regression of the ridge and plus. However, there was a peripheral avascular retina, which on subsequent follow-up led to a reactivation of the disease, as is appreciated by the dip in this graph. However, these eyes then received additional treatment, following which all 30 eyes showed regression of the disease. So disease reactivation in the ranibizumab group was seen in 24 out of 30 eyes, with a mean time to disease reactivation of 6.8 weeks. 28 out of the 30 eyes in injection group and 10 out of 30 eyes in the laser group required additional treatment in some form. The mean temporal disc to ridge distance was measured for vascular regrowth, which increased from 15.2 mm pre-procedure to 17.2 mm after the injection at 24 weeks follow-up, an increase of 13.25%, which was found to be statistically significant. So the procedure duration for the injection group was found to be significantly shorter than the laser group. The laser group, 2 infants developed systemic morbidity during the procedure and required a subsequent second sitting, and one infant developed post-procedure systemic morbidity. The post-procedure monitoring duration, the median duration was 3 hours in both the groups, and none of the groups had any procedure-related ocular complications. The median refractive error for the injection group was 0.25 diopters, and for the laser group was 1.5 diopters. However, since the refraction was done after the additional treatment was given, the true effect of the initial treatment could not be ascertained. So final outcome at the end of 24 weeks, all 30 eyes in both the groups showed complete disease regression. So these are the RED-CAM images. This image shows zone 2 stage 3 plus ROP, which regressed with injection. However, there was reactivation of the disease at 4 weeks, and finally laser was done, which showed complete regression of the disease. This is an infant with zone 2 stage 2 plus ROP, for which laser was done and the disease showed regression. So complete regression was achieved in zone 2 type 1 ROP in both the groups by 12 weeks. Intravitreal ranibizumab was found to have a shorter procedure duration and less procedure-related morbidity. It caused a faster disease regression and vascular regrowth, but it has a higher reactivation rate, which still needs additional laser treatment. The limitations of the study was that superiority of ranibizumab could not be established due to small sample size. The study was not masked owing to the marks which are made by laser therapy. The full extent of vascularization which can be achieved with ranibizumab could not be assessed, as rescue laser was done for reactivation in these eyes, and it was difficult to assess the true effect of intervention on refractive error, as this was done after the additional treatment. So we concluded that laser is still the preferred choice of treatment for zone 2 type 1 ROP. However, intravitreal ranibizumab can be used in selected cases of zone 2 type 1 ROP where benefits of faster regression, as in threshold cases, less procedure morbidity and procedure duration time, as in sick infants, and vascular regrowth, as in more posterior zones, can be obtained. However, since ranibizumab still has a higher reactivation rate, the effect of longer acting anti-VEGF drugs needs to be explored in the future. Thank you.
Arpita, first appreciation for you said you were ophthalm resident. Can you hear us, Arpita?
Yes, sir.
Yeah, so appreciation for you because ophthalm resident, you submitted this paper for a neonatal conference.
Thank you, sir.
So we really appreciate that, and a reasonably good study with good conclusions. And what is your current change in practice that you follow now? Which are the candidates you choose for the alternative intervention based on your study? So are there any specific knowledge that you gathered from this?
So what we've gathered is we would still continue to prefer laser over injection for zone 2 ROPs. However, in more posterior zones, in which we would get the benefit of vascular regrowth, we would prefer to give injections in such cases. As well as in sick infants, we would prefer to go ahead with injections since the risk of procedure-related morbidity is lesser.
Right.
Arpita, this is the another monoclonal antibody which we were reading and using earlier. Why did we choose ranibizumab? This is a new protocol now giving ranibizumab.
I didn't get you, sir.
The other monoclonal antibodies which are being bevacizumab.
Bevacizumab.
Yes.
Bevacizumab was initially used by the BEAT ROP trial.
Yeah.
However, its use in ophthalmology is still off-label. So ranibizumab is the currently only
That is, with label which is available. Yeah. Okay.
So.
Subhash wanted to ask.
I just wanted to share something like in our hospital too. Can you hear me?
Yes.
I'm one of the audience. Like in our hospital, in Army Hospital, R&R, we see a lot of ROP cases, and what our experience is that it just delays the laser. I mean, you land up actually giving laser to the babies, but then it gets delayed because of ranibizumab. The only advantage that we got is that in small babies, like 24, 25 week babies, the eyes are so small that it is technically often difficult to do a laser, or so there it helps. That's it. Otherwise, they'll end up doing laser anyways. That's what our observation is.
Only benefit that we get is that we can give some amount of vascular regrowth in the periphery to preserve some amount of visual field for the baby, for the infant. Otherwise, laser has proved to be better.
So, Arpita, in a NEEV program, the newborn early evaluation program, ROP screening is going on in Delhi in many hospitals. And Dr. Shadinder Sabharwal from Shroff actually was the same opinion as which Subhash said. In very small preterm babies where you really find it difficult at points, the technicality of doing an ROP again and again and actually instituting laser, they are giving monoclonal antibodies actually help delay it. And but you cannot just forget about it. You have to do it again and again so that the risk of recurrence is always there.
Yes, sir.
Thank you.
Thank you, sir.
Next is KMSK Krishna. Krishna is online. Krishna was there in online.
Sir, am I audible, sir?
Yeah.
Sir. My slides are visible, sir. Sir. Hello, sir.
Yeah, you can start. We can see your slides. You can
Sir.
start the presentation.
So, I have, good afternoon, everyone. I'm going to present my paper on validity of intergrowth 21st growth standards for the diagnosis of intrauterine growth restriction in the neonates. We have conducted this study in Command Hospital, Pune. So, coming to introduction, IUGR is a disease in the newborns which requires an early identification for the postnatal nutrition and anticipate morbidity, especially in the preterm babies. As we all know, the IUGR we cannot use synonymously with the small for gestational age. IUGR is we consider IUGR when there is a clinical evidence of malnutrition, which we can assess anthropometrically, but by weight at the birth, less than 10 centile on the growth charts, or anthropometric other indices like ponderal index and clinical assessment of nutrition score. Among them, clinical assessment of nutrition score as proposed by Metcalf et al., has better ability to predict the nutrition status at birth. By using the birth weight charts and along with the CAN score less than 25 for assessing the malnutrition, we diagnose the considered as a gold standard for the diagnosis of IUGR. However, intergrowth charts which were developed also have got the ability to detect nutritional status and birth size, size of the birth, which if less than 10 centile is considered IUGR. So there exists a limited information on validity of intergrowth 21st charts in our population. So we aim to conduct this study to detect the compare the intergrowth 21st charts with the Fenton charts for determining the incidence of IUGR and ascertain the validity of these charts. So what we did is we included all newborns with antenatal diagnosis of IUGR and birth weight less than 10 centile on Fenton chart, and all the newborns with birth weight less than 10 centile and CAN score less than 25, indicating in utero malnutrition. So we excluded neonates with dysmorphic features, anomalies, and birth weight more than 10 centile, even if they had a morphologic IUGR. So the study period was between October 2019 to March 21st. We enrolled neonates between 28 to 42 weeks period of gestation, and the index test was intergrowth, and reference standard was a Fenton, and we considered gold standard as a Fenton weight centile less than 10 and CAN score less than 25, and we plotted all the three parameters of weight, length, and head circumference on both these charts, and we also assessed the nutritional score by doing the CAN score assessment at birth. We have enrolled 120 neonates based on the 120 neonates. Out of them, 10 neonates we have excluded in view of morphologic IUGR. 10 neonates we have included who had antenatal FGR and weight centile less than 10, and 70 neonates who had weight centile less than 10, CAN score less than 25, and 14 units with weights less than 10 centile and CAN score less than 25, and antenatal diagnosis of FGR. Out of them, 10 were excluded, and 110 neonates were enrolled. One were included for analysis. 110 neonates were classified after CAN score assessment. Out of 110 neonates, 98 neonates were classified as IUGR, and 86 neonates were classified as IUGR based on 86 neonates were classified as SGA by intergrowth. By doing the CAN score, we excluded the who had CAN score values more than 25, and 78 neonates we are included as IUGR based on birth weight less than 10 centile and CAN score. So outcomes we have analyzed is sensitivity, specificity of Fenton and intergrowth chart in diagnosis of IUGR, and secondary outcomes we have analyzed are incidence of IUGR at different gestational ages and incidence of extrauterine growth restrictions. These are the baseline characteristics. Almost 50% of the population were male and female. Period of gestation, most of them were belonging to the 35 to 37 weeks period of gestation, late pretermers, and birth weight was most of them were low birth weight, with only 2.5% of the population constituting extreme low birth weight. The characteristics of the population are mean birth weight of gold standard population, that is Fenton less than 10 centile and CAN score less than 25 is 1884 grams, and mean birth weight of reference standard population, that is Fenton, it is 1900 grams, and mean birth weight of index stress population SGA alone is 1790 grams. So coming to the results, the incidence of birth weight centile less than 10 on Fenton and intergrowth charts. Fenton growth chart has shown more number of babies with weight centile less than 10 compared to the intergrowth chart, and this is a primary outcome. The sensitivity of Fenton when compared to the gold standard is 100%. Specificity is around 45%. The positive predictive value is 89, and the negative predictive value is 100, and accuracy of the test is 90%. Coming to the intergrowth chart, when compared to the Fenton, the sensitivity is 78%. However, the specificity and positive predictive value are 100%, and the negative predictive value is low, that is 29%, and the accuracy is 80%. This is a secondary outcome, the incidence of IUGR at different gestational ages. We have, we can notice that among the gestational ages, across the gestational ages, the incidence of IUGR is increasing. But however, in the very preterm, the incidence of IUGR remained the same. But in moderate and late preterm, there was a difference between Fenton and intergrowth chart in terms of detection of IUGR. And based on the and another outcome is secondary outcome is incidence of UGR extrauterine growth restriction at discharge on Fenton. It shows almost among the NICU admitted neonates, almost all the babies had a extrauterine growth restriction, that is 100% in terms of weight, 76% in terms of length, and 75% in terms of OFC. So to discuss, we use the combined Fenton and CAN score and birth weight less than 10 centile as a gold standard, and we tested it against the intergrowth chart. And to consider, we also notice that there is a higher specificity of intergrowth chart in detecting the IUGR. The Fenton charts are intrauterine growth charts based on the normalized values from the cross-sectional data of a term infants. They are growth references and they are not standards. And newborns nutrition status, physiological weight loss, they are not addressed. However, intergrowth charts are recommended as they are prospective charts to describe the normal fetal growth, preterm growth, and newborns nutritional status. They are population based, multi-ethnic, sex specific, and longitudinal charts. So based from my study, I conclude that intergrowth charts are more specific and have a good positive predictive value at identifying IUGR in neonates between 28 to 42 weeks period of gestation. Thank you.
Thank you, Krishna. Actually, can you just go back to the slides where you were comparing intergrowth with the Fenton reference? The 12 number. 12 number slide.
1 second.
12 number slide.
Sir, I'm going.
I can see from there. You just click on.
Sir.
Yeah. So here you are comparing Fenton and not Fenton plus CAN score. Why?
Sir,
you said Fenton plus and CAN score combined was the gold standard. But here you are compared. Is it Fenton plus CAN score or only?
Yes, sir. This is Fenton plus CAN score, sir.
So you have not written that.
I have sir,
you have not
Fenton
written
plus
it this way because here in that slide it was Fenton plus.
Yes, sir.
So,
I mentioned it.
So how much difference having a CAN score made to the Fenton when you compare? Just go back to the 11 number slide. Just back.
So it's around 20% difference.
No, with Fenton plus intergrowth when it was coming. But when you're comparing Fenton with Fenton, then it was the same. Just next slide.
Sir.
Yeah. So almost 98, almost 100% were showing. Using CAN score make a difference?
Yes, sir. CAN score had a
because
difference.
Using Fenton and Fenton, they were absolutely together, isn't it?
Sir, Fenton, out of the, sir, that's what I have shown in the flowchart also, sir. Out of the 110 neonates who are classified as Fenton, as SGS, when CAN score was applied to them on the Excel, they have only 98 neonates were classified as IUGR based on the Fenton, sir. So when
yes, that's fine.
Out of these 110 units, when I applied the intergrowth chart, when they have plotted them, they were 86 units coming below the 10 centile. However, when I applied the CAN score more than 25, then 78 units were classified as IUGRs.
So more or less number over there. Okay.
Right.
So this is how does it reflect in our clinical practice? How does it change our practice? Does it using intergrowths will make us more relaxed about the weights of the baby, or the anxiety of the parents and the physician when we know the weight continues as we are still doing following Fenton?
Sir, Fenton's growth charts are basically they are studied from a cross-sectional study, sir. They are not studied they are not specific for a study based
I was
on
just asking, if you are a parent or if you are related with the parent, which chart you will prescribe to them? Intergrowth chart or a Fenton chart?
Sir, there is a limited data about the intergrowth charts in our study.
Even after your
population,
study,
sir.
even after study, you said you will be happier telling them they are okay, they are not that IUGR, isn't it?
Yes, sir. Based on my study, I will prescribe intergrowth charts, sir.
And your EUGR number was also decreased by 50%, almost 50%. So otherwise, they would have been fed with a lot of 45ers, and the parents' anxiety would have continued, isn't it?
Yes, sir. I will say that EUGR compared to Fenton is low with the intergrowth.
That is the positive predictive value which you are showing in the conclusion.
Yes, sir.
Thank you.
Sir.
Good afternoon, sir.
Rajkumar.
Good afternoon.
Dr. Rajkumar.
Sir, I am Dr. Anjali.
Good afternoon, sir. Dr. Rajkumar.
Anjali is not in our forum. Please, Anjali, you go to some other room.
Sir, the thing is, I have been asking for the room that I am not getting the link. And the hall 2 link has been taken by poster presentation and we don't know where to.
Presentation here. You can take it. Yeah, you have a presentation, but first let Rajkumar have it, then we'll take it.
Yes, sir. Good afternoon, sir. So my slides are visible, sir.
You can start. We can see your slides.
Good afternoon, sir. Actually, my topic today is weight loss among exclusive breastfeed neonate. So it is a prospective study which is done in Command Hospital, Pune, sir. So I start with the introduction part, sir. So all the breastfeeding unit lose some weight in the early days of life, and after the maturation, there is a efflux of fluid from the ICF to the ECF compartment, and this increase in the ECF compartment fluids float the kidney in a salt and water diuresis by 48 to 72 hours, which causes a weight loss, sir. So for the first 2 days of life, the breastfeeding infant receive only small amount of colostrum, and after the lactogenesis stage 2, the secretory activation begins. Usually on the day 3 of life, the most infant gradually begin to gain weight, sir. So the aim of the study and the objective are to study the postnatal weight loss in 72 hours in exclusively breastfeed neonates, and to describe the pattern of weight loss by selected maternal and neonatal factors like maternal age, education, mode of delivery, lactation support, priming or multigravid, and the neonatal jaundice. So the materials and the method which I use, I include all the healthy neonates more than 35 weeks of POJ born by vaginal or the cesarean section at Command Pune, and the criteria which exclude are preterm neonates less than 35 weeks of POJ, birth weight less than 2 kg, IUGR babies, and multiple pregnancies. Unit who receive supplementary feed, that is our main criteria, and unit admit in the NICU, sir. And the study was begun in November 19th to November 2020, and all unit fulfilling the inclusion criteria room with mother in postnatal ward, and breastfeeding was started within 1 hour. So basically, the child who just born by vaginal route or by the LCS is a child born by vaginal route. We begin the feeding as soon as the baby birth comes out, and we generally starting within hours. Maybe within half an hour we start, but if a baby was born by LCS, so we start the feeding in the OT, sir, after the baby is born. At least we feed for 10 to 15 minutes in OT with permission from mother. We ask, then only after feed. So we try to feed every baby, maybe born by vaginal route or by the LCS, in OT or in the labor room, sir. That is our first priority. Even we always do. Until unless there is some complication like mother was under GA, sir, so we don't. Otherwise, we feed all the babies. And after that, when the baby come to ward, sir, we take a weight of the baby in the machine we have, sir. So the naked weight of these units were recorded on the day 1, day 2, and day 3 of life in the hospital stay using an electronic baby weighing scale machine, that is Goldtech digital machine, with accuracy of 5 grams, sir. So the number of babies which are eligible for my study, there was 660, sir, and out of 660, 35 were discharged on day 2, so I have not taken these babies which are on the right side, sir, and 20 weight could not be taken because of some issue. That time there was no nurse or there was no doctors, or it was some delayed, sir. And 5 minutes developed sepsis, so they were on antibiotics, so we had not taken their weights. Though the number of babies was total 600, and we monitored the weight, baby's weight in the ward with every day, sir. And that's a basic characteristic to all the babies and mothers. So the mean POG of around 38 weeks, sir. The term which was 64, it is 94%, and preterm was more than 35 weeks, but less than 37 weeks, sir. They were around 6%, and mean maternal age was around 27 years of age. The gravida wise, majority were primary gravida. Majority were some multi-gravida, which is 54%, and then foot score primary gravida, sir. Sir, motor delivery was basically 50% of normal delivery, and LSCs of around 43%, sir. And maternal, sir, comorbidity what we have taken is only LSCs, GDM, anemia, and the hypertension. There are multiple other things, but we have taken all these only 4, sir. And out of these, the mother who having previous LSCs was around 27%, and GDM was around 25%, anemia was having 25%, and hypertension was around 22%, sir. Regarding the education status of mothers, because that also actually help to understand the mother, how she know, or what she know about the feeding of the baby. So maximum mothers were graduates, sir, because we are in armed force, and the maximum of our troops wise, so they are studied, sir. So they are around 51% of the mothers were graduates. 12th pass were around 44%, and they were illiterate. Maybe they have passed 5th, 8th, or 9th. We don't have asked, sir, but they were around 4%. And the gestation wise, the term babies, which is more than 37 weeks, they are around 94%, and preterm was around, which I already covered previously. And regarding the maturity of the baby, sir, so AG around 94%, then SGA 4%, and LG 0.3%, sir. And gender of unit around 52% of male and 48 of female, sir. So now I come to the my results, sir. The mean age of around mother was around 27 years of age, and the 46% were primary gravida. The average time of the starting of feed was around before 1 hour, sir, because we feed every kid who born in the labor room or in the OT. So it was around 1 hour. But the weight loss percentage on day 1 was around 4.2%, day 2 around 7.15%, and day 3 was 7.42%, sir. But there was no statistically significant association with the maternal risk factors or the neonatal clinical course in the study. And so now I come to my conclusion part, sir. Basically, we have checked all the studies previously. So in our study also we find out that the pattern of weight loss in among healthy exclusive breastfed neonate, the term unit was similar to the previous studies, sir. So basically, the point of the studies are basically we want to feed every kid from mother. We don't want to give any kind of formula feed, sir. We generally don't feed any kid in our ward with formula feed until there is an emergency or mother is not available at present time. We try to borrow the EBM from other milk with the consent. Otherwise, we
thank you,
yes,
thank you, Rajkumar.
Yes, sir.
I think you have. So, what was your main objective? Was to note the weight loss.
Yeah, sir. Weight loss, because previous studies they were showing some.
Not because I just. What was the main objective of doing a study?
Weight loss, also weight loss or pattern of weight loss you want to see, sir, on day 1, day 2, and day 3, sir. On babies who are only on the breastfeed, sir. There was no on the top feed, sir.
So your premise was your first line was all babies on breastfeeding lose weight.
Yes, sir. Some
Does
weight.
it stand correct for everybody, or for some SCA they may not lose weight from?
Sir, every baby will lose some weight after birth, sir. It's for every baby, sir. Maybe every baby will lose weight, sir.
Even for very small for gestation age babies who are directly going for catch up also.
Sir, initial days they will lose weight. Then later.
You are very sure they will lose weight only. So yes, they were supposed to lose weight. They lost weight. So what was novel in your study?
Actually, our basic concern was if we feed, we generally worried about if a baby won't take mother's milk, sir. We put them on formula feed, sir. We were actually
so
giving.
That was your concern.
Sir, so we want to see whether the weight loss we are giving the breastfeed, it is more or it is like what we see, sir. If we don't start on them on the formula feed, they will lose more weight, sir. We want to feed them as whatever the option we have, sir. So we want to see if
you did not test that whether it reduced the anxiety of the the caregivers?
No, sir,
about the
actually, we
weight?
used to counsel. Sir, it's a morning also, evening and night. We always counsel parents, and we have taken lectures, we have taken the videos, we have to show the
So
posters,
this was
sir.
not part. This was not. Achha, another thing, Rajkumar. In the photo, you just showed me the photograph where baby was being weighed.
Yes, sir.
How do you clean this weighing scale?
With the stylium, we used to clean. Sir, morning, sir, when we take
So
weight.
after every baby, you clean it?
Yes, sir. Yes, every baby, sir. Every baby, sir.
You put the baby on this platform directly.
Yes, sir. Yes, sir. Yes, sir.
Anything you could have done better?
Sir, we put some small cloth below it, sir. But sir, that thing, because that actually contaminate every baby, sir. So we don't want to put clothes, sir. So we can do it, sir.
You
but
clean. How many babies do you weigh with on one machine every day?
Sir, it depends, sir. Like in so generally we have 20 babies in a day, sir. So morning 20, and we have actually 2-3 wards, sir. So in one ward we have each machine, sir. So it
you clean it after use with every baby. Yeah.
Yes, sir. Yeah, every baby, sir. Every baby is to clean, sir.
Thank you, Rajkumar.
Right, sir. Thank you, sir.
So Anjali, are you there?
Anjali.
Anjali, are you there?
Yes, sir, I am there.
Yeah. See, what has happened is we have no idea about the other hall or the links. But
what is your number?
So my number is actually 16, sir. Morning, I am not present because I did not get the link. And since then, I've been contacting Nitin, sir, and others.
It was in the morning link.
Yes, sir.
Okay.
So they told I can present in hall 2.
You can give us your number, your name,
Yeah.
area of your study, and we can assess you and pass on the sheet to the organizers.
What is your OFP number?
16, sir, 16.
Okay.
OFP number 16, and you are Dr.
Anjali S. Raj.
Just carry on.
Unless you spread on your study, we write it down.
Yes, sir.
So, Anjali, you can share your screen and start the presentation. We will do an assessment.
Like, can I do it now or should I wait for after one more?
No, you can do it right now.
Okay.
Yeah, and we will pass it on to the organizers.
Okay, fine, sir. Fine, sir. Just a second.
You can start. You have 6 minutes for presentation.
Okay, fine, sir.
मेरे इंट्रोडक्शन में 2 मिनट 2.5 मिनट का तो हो गया ना मैं तो नहीं
Sir, are my slides visible?
Yeah.
Yeah, I'll start.
You can see them. You can start the presentation. Just make it full screen and start.
Yeah. So good afternoon, everybody. My presentation is on impact of maternal COVID-19 infection on exclusive breast milk feeding of low birth weight infants, which was a retrospective cohort study. I'm Dr. Anjali, and I am coming from St. John's Hospital, Bangalore. So to begin with, when the maternal COVID-19 infection came in, we know that it actually affected the newborns. There was a fear of transmission to the babies. There was undue separation initially. And we also, by the inter-COVID multinational study, we knew that it also increased prematurity and there was some amount of compromised care. So all this we postulated could have led to reduced breast milk feeding. And then we saw that so far only single study was there, which was done by Espeng et al., which postulated around 36% difference in the breastfeeding rates between maternal COVID exposed neonates versus those who were not. So we wanted to know what is the impact of the same in the Indian scenario, especially in the low birth weight neonates who definitely need breastfeeding as much as any other neonates. So our primary objective, we made it in the PICO format, and we got that we will study all the inborn low birth weight neonates less than 2,500 grams exposed to maternal COVID-19 infection as compared to the unexposed low birth weight infants. And we will see the outcome of their breastfeeding practices at discharge over a period of 1 year, that is from July 2020 to August 2021. The secondary objectives were the exclusive breast milk feeding rates at 3 months, need for NICU admission, excessive weight loss, hyperbilirubinemia, RDS and BPD, a need for invasive and non-invasive ventilation, NEC sepsis, and duration of hospital stay. So the methodology used was all inborn low birth weight infants were studied. It was a retrospective cohort study, and all the death and DAMA were actually excluded. We got the retrospective data from NNPD and our COVID-19 database, and the data that was analyzed thoroughly for baseline information and the clinical profile of the neonates during their hospital stay. And the follow-up was actually taken by contacting the parents telephonically and to ask their feeding practices at discharge in the 3 months. And also we took a verbal consent at that time. So the results were the total live births during the study period were 1,996 and total low birth weight infants were 402. And those who were exposed to maternal COVID-19 infection were 48 and those who were not exposed were 354. Out of the exposed 48, one died and so total number was 47. Out of was the unexposed, there were deaths of 4 and DAMA was 10 and we could not follow up telephonically on 190. So the total number was 150, which we followed. So the baseline parameters of the two groups were almost similar and did not have any significant difference. The mean birth weight was 1,051, whereas here was 1,038. Even the gestational age was comparable. Coming to the prematurity, even the prematurity rates were comparable between the two cohorts. What actually caused a significant difference was those who were exposed, the COVID-19 exposed neonates had higher number of were born with higher number of cesarean section, which was statistically significant. And we postulated that this might be one of the causes. The primary outcome, which we saw that the exclusive breast milk feeding at discharge was actually kind of almost 24% difference was seen in between the two cohorts with a risk ratio of 6.9 with a p-value of less than 0.001. The causes of reduced breast milk feeding at discharge, predominantly in COVID-19, what we found was maternal illness and maternal death. And initially, our policy was to kind of early separation between the mother and the baby there, because we were not sure how the infection transmission was happening. But later on in the second epoch, we actually did not do that. Actually, that reduced the amount of separation. And the other causes were idiopathic and twins. In the unexposed group, the more of reduced milk feeding was secondary to the drug exposure or drug in the mother, and others were twins and other things. The secondary outcomes also, when we saw at 3 months, this difference persisted and in fact increased to 36%. And what we found was the risk ratio still remained 2.6 times higher and the p-value was quite significant. The causes of reduced breastfeeding even at 3 months was again predominantly maternal illness. But what we found was the early separation, which we did earlier, 3 of them could actually relactate and were actually about to breastfeed better. But there were other causes of idiopathic causes which were actually predominated in the at 3 months. And in the COVID exposed, as well as the idiopathic causes actually kind of predominated. Coming to the comorbidities, what we found was the NICU admission did not change, but hyperbilirubinemia, weight loss were predominantly more in the COVID-19 exposed neonates, which might be secondary to the increased cesarean section. And also the compromised, the lactation care and everything was not able to give more. So it can be a spectrum of the whole thing, what we did. Sepsis and NEC and the duration of hospital stay did not actually differ between the two groups. So conclusion was maternal COVID-19 infection definitely, it increases hyperbilirubinemia and causes excessive weight loss. It can be a spectrum of the whole thing. And what we learned was this is preventable, and focused nursing care, reduce separation with precautions, and lactation support and counseling to the mothers and human milk banking can actually kind of help us in reducing this difference in the breastfeeding rates. So the limitation of my study is it is a single center study and there are some missed data. Thank you.
Anjali, very pertinent study and very well done, because this is currently the most researched and the most essential interventions that we need to know. Yes, I think the conclusions that you've drawn are reasonably good, but I think in spite of what WHO recommends, still most professionals, most hospitals don't follow. Sometimes even the family does not agree to continue breastfeeding, keeping the baby with the mother. But I think overall a very relevant and good study. We have put down your marks and we have taken a presentation as done. And we will specifically tell the NMF office about this when we hand over this sheet that you finished your presentation. So you get your certificate.
Thank you, sir.
And if there's any problem, you write a mail and say that you presented in the Ebony Hall. And the judges are Dr. Vaidya and Dr. Surinder Bish. So in case you have any difficulty, you can mention our names.
Thank you so much, sir. Thanks a lot. It is a great
Sure.
help to me. Thank you.
All the best.
Thank you, sir. Thank you.
I think would have taken the gold standard.
Hello, sir.
Instead of Bible to take the Franklin as a gold standard presentation.
Hello.
Franklin cannot be taken as gold standard. Correlation study has to be done instead of doing the sensitive study.
The issue is now when you have a better and a more recent growth chart that is in your country.
Hello. Hello, sir. Am I audible?
Sir, ಎಲ್ಲ ಹೋದ್ರು ಮುಗೀತು.
Hello.
You have to go now.
Excuse me, sir.
Hello. Am I audible?
Excuse me.
Can I have the mic?
Hello.
Hello, who's this Tandesh?
Yes, sir. Sir,
What
my
is this?
my OFE is 47. I was supposed to be in hall 2, but from last 2 hours, that has been occupied by poster and nobody is showing out there. I need to present that paper, man.
Tandesh, I'm one of the judges for this hall, and we are not really aware of what the organizers have intended and what they did to the links. So I will pass on your message to Neetu. Tell her to call you and see what can be done. But we are not in the position because we do not know what's happening in the other hall, and we do not know who is going to send the link. So there is some confusion, but I'm writing your name down and I'm passing it on to the NLF secretary to sort out this matter.
Yes, sir. Sure. Thank you.
Excuse me, sir. I'm Dr. Deepthi here.
Yeah.
I'm waiting for the last 2.5 hours. My paper presentation under the innovation category was supposed to be at 2:30, but I've been juggling through multiple halls, but nowhere.
What happened is, because we are just the judges, we were just told to judge this hall. So we are not part of this organizing process. But what I'll do is I've been taking down both your names and numbers, and I'm handing them over to the NF secretary so he calls out and sorts out a presentation. So I regret the inconvenience, but it's, the judges don't have any role to play here in the.
Yes, I totally understand. I even contacted one of the the contact persons.
Can you do one thing? Can you do one favor, both of you?
Yes, sir.
Take down my cell number.
Yes, sir.
98220.
So may I know whom I'm speaking to, sir?
Dr. Umesh Vaidya.
Yes, sir.
220.
Yes, sir.
31151.
220-31151. Yes, sir.
Both of you send me independent texts with
Okay,
your paper number, which hall you're supposed to present, and you clearly write that you did not get a link and you could not find the hall. So you please send me independent messages. I'll pass it on to the NF secretary and see that he attends to that. Write your cell numbers also in the message. So he will call you.
Sir, I'm Dr. Nazira. I'm OFP 42.
Okay,
Which is
so
the
I think
hall I need to
I know,
present?
see, what has happened is that we have finished our papers, and we do not know exactly about the other halls. But if the three of you send me independent messages, I will see that the NNF office will act on it and see that something is done, and they call you and sort this matter out.
Sir, my post number is 78. Ours are also not done. In that paper 2 link, no, everyone is waiting actually.
I know, but what happens is that I have just finished my job here, and we were not involved in the organization. We were just given this assignment by the office, and we've done that.
So long that no one is picking up, and everyone is they're just juggling us everywhere.
So no, don't do that now. Just send me a text message. I'll straight away give it to the NNF secretary and tell him to act on it immediately. So
Can you tell me your number once?
Yeah, 98220.
Yes, sir.
31151.
Thank you, sir.
And I'm Dr. Umesh Vaidya. So you send me that messages, write your cell number in it, write exactly what happened. I'm going right down to the main hall for the general body meeting. I'll pass it on to the secretary and tell him to call you individually and answer
Yes,
this
sir.
problem. Okay, so
Definitely.
sorry, but we are helpless because there's a lot of chaos in this whole place.
Thank
Okay?
you, sir. Thank you, sir.
Excuse me, mine is OFP 37. Can I?
Mohammed, what happened is that they took the attendance in the beginning, and the other judges already left now because the general body meeting has started at 5. So what you can do, you also please send a text message to me. We will see whether we can arrange a separate session for you.
Okay, sir. So can you just please tell me your number again?
98220.
220. Yes.
31151. And I will see that they arrange a special session and get these things done properly.
Okay, okay.
Write your cell number so they'll be able to call you.
Sir, text message or WhatsApp message, sir?
Either one.
Okay.
Okay, so we'll see that something is done. You don't get worried. I'll see that something is done.
Nine 31151.
Off mode.
Sir, can you please repeat your number once more, sir?
हाँ हेलो तन्मेश, क्या आपका ही प्रेजेंटेशन था?
हाँ मेरा प्रेजेंटेशन था ना।
मुझे पता है, नहीं
Is this group still active?
कल तो हमारा घूमने जाने का प्लान था। अब नहीं है, फिर बंद कर दें।